welcome everybody, and thank you so much for tuning into this live case discussion on complex lower extremity trauma. It's really a pleasure to be here today. This conference is presented by the faculty and staff of the Harvard Global Orthopedics Collaborative alongside SONA Global. So the Harvard Global Orthopedic Collaborative is a group of Harvard-affiliated orthopedic faculty and trainees who are dedicated to improving access to musculoskeletal healthcare globally. SONA Global is a nonprofit organization which aims to improve essential trauma care by providing free virtual education like this one, alongside affordable devices. So SONA Global has actually developed a low-cost negative pressure wound therapy device and affordable external fixator. You can learn more about that at sonaglobal.org. So all of us at HGOC and SONA believe that high-quality education and training should be available to all, regardless of where you work. So when we collaborate, sharing knowledge, ideas, and also our challenges, only then can we work together to improve orthopedic surgical capacity worldwide. So it is our pleasure to organize educational webinars such as this one, fostering dialogue between colleagues all around the world. So next slide, please. We are very proud to be running this conference in collaboration with the South Sudan Orthopedic and Trauma Society, as well as World Orthopedic Concern. And you'll get to know a lot of the faculty associated with these two organizations today. Next slide. My name is Kieran Agarwal-Harding. I'm the director of the Harvard Global Orthopedics Collaborative, and I'm joined by my co-chair, Dr. Brian Madison from South Sudan. Brian, I'll let you say a few words.
I think I'm having a lot of echo here. But my name is Dr. Brian Madison, and thank you very much for joining us in this course. I would like to take this opportunity to, thank everyone who is contributing for the success of this conference, and we are really, really thrilled to launch this conference in collaboration with Harvard Global Orthopedic Collaborative, as well as SONA Global and SOTS. A lot of heroes have been doing a lot of work on the background, and I would like to thank everyone, especially Dr. Nak, Yak, Kiran, and the team, the faculty behind. My appreciation also goes to the team from SOTS for taking some time and prepare these presentations. I would like to take a moment to express our sympathy with the Sudanese people. They've been in a bad conflict, and these are two nations which are bound historically, and we have a very big South Sudanese community up in Sudan who are caught up in the war. So I would like to appreciate my sympathy with them, and we hope that everything goes well. Apart from that, welcome to the conference, and I hope you guys have a fruitful discussion. Thanks.
Thank you, Brian, and thank you for those words in solidarity with the Sudanese people. We, any war is horrible, and so our thoughts and prayers are with all those who are affected. Next slide, please. So today we have some really remarkable cases for presentation. Many cases will be presented from our colleagues in South Sudan, who we're very proud to be running this conference in collaboration with. We'll be hearing from Dr. Mapour, Dr. Omojok, Dr. Brian Madison, of course, and Dr. Emmanuel Abour. Next slide. We'll also be hearing cases from all around the world. We've got Dr. Abraham from Addis Ababa, Ethiopia, Dr. Mariam Jouf from Gambia, Dr. Wahidullah Mohammadi from Afghanistan, Dr. Marcelo Ryan Coker from Kenya, Dr. Daniele Scuto from Kenya, and Dr. Walid Sharaf from Yemen. So I really hope that you'll enjoy these cases. Next slide. And of course, we have really remarkable faculty who are here to provide discussion and flavor to the conversation as well, and their commentary on the cases. So from World Orthopedic Concern International, as well as the UK, we've got Dr. Arindam Banerjee and then Dr. Deepa Bose. From University of Missouri, we've got Dr. James Cook and Dr. Gregory De La Roca. Next slide. From WOC, Dr. Mohammed Fadel, and then from Yale, Dr. David Frumberg, from Ethiopia, Dr. Ephraim Gebrehana, and from Brown University, Dr. Roman Haida. Next slide. From University of Missouri, Dr. Mauricio Kufuri. From Gambia, Dr. Keva Marena. From University of Missouri, Dr. Kyle Schwesser. And my partner from Harvard, Dr. Jack Wickstead. Next slide. And of course, to echo Brian's lovely comment earlier, I really, have to give my thanks to this amazing team at HGOC and Sona Global for having organized this. All of the educational videos that you guys found online, all of the course content that was curated and put together, really big thanks to everybody who was involved. And I have to give a special shout out to Yak Nak, who is running the slides right now and was the person who really established this connection between South Sudan and HGOC. So thanks so much to the entire HGOC and Sona team. Next slide. So today's agenda, we'll have a brief introduction, which is almost over now, and then we'll move straight into session 1, where we'll talk about traditional bone setter related complications. 2 presenters from South Sudan will be taking us through those cases. Then we'll have a brief break and then come back for session 2 on complex polytrauma. We have some great cases for that one as well, including mainly firearm-related injuries, which is something that we're all thinking a lot about given the situation on the ground in Sudan and several other countries. And then session 3, we'll move on to post-traumatic reconstruction. We've got some great cases related to bone transport. And then we'll conclude. And there's a little bit of a breakout room for networking and conversation afterwards. Next slide. So course objectives, we're going to improve participants' knowledge of complex lower extremity trauma management principles. We're going to foster international discussion regarding orthopedic trauma care delivery and motivate and support the younger generation of orthopedic surgeons practicing in low and middle income countries. That's really the focus of these conferences. Next slide. So as you guys all know, our course structure, on Sunday last weekend, we launched our self-directed learning guide. And I really hope that you guys all had the opportunity to go through those lectures and articles in preparation for today's live session. Next slide. The self-directed learning guide has recorded lectures by international faculty, many of whom are here today. And we really thank them for taking the time to record those lectures for us. And then, of course, we have some relevant articles. These are curated by the staff, specifically related to the topic today. Next slide. And here are all the fantastic lectures that are available for free. They're all on YouTube. Anybody who got the PDF copy of our learning guide should be able to access those, but they're also freely available on YouTube for anybody who's interested in listening to them. Next slide. So without further ado, I'll hand the mic over to our first speaker for our session 1, managing traditional bone setter related complications. Next slide. We have 2 speakers. The first will be Brian Madison, and then the next, Dr. Omojok Bache James from South Sudan. So without further ado, Brian, please take it away for your first case.
Thank you, Kiran. I'm going to present on tibio-talar calcaneal nail, retrograde fixation of neglected ankle fractures using sign nail. Next slide. I declare no conflict of interest. Next slide. So I'll just give you a brief about myself. My name is Dr. Brian Madison. I graduated from the University of Juba when I was studying Khartoum, Sudan in 2009, and then did my MMed in orthopedics and trauma from Tanzania in the beautiful city of Moshi. And then for some reason, I did a diploma in tropical medicine and hygiene from London School of Tropical Medicine and Hygiene, the East African program. Then I went for a one-year fellowship program in orthopedic trauma in Hamilton, Ontario. Currently, I practice as an orthopedic surgeon at Juba Teaching Hospital, as well as a lecturer at the University of Juba Department of Surgery. I'm the inaugural president for the South Sudan Orthopedics and Trauma Society. Next slide. So I would just like to give you a brief on the society. We're just collaborating with Harvard Global Orthopedic Collaborative. So our society is called the South Sudan Orthopedics and Trauma Society, SOTS in short. It's actually a professional society that brings together orthopedic surgeons, surgery trainees, and diverse medical professionals with interest in the field of orthopedics. We are a not-for-profit organization that focuses on unifying these roles towards the common goal of enhanced patient care healthcare professions' welfare as well as transform lives. We think that these other allied professions are very, very important because we really, really value teamwork. Next. Next slide, please. Next slide. So the society was established in June. Can you go back a little bit? Sorry. So the society was established in June 2021. So it's only 2 years old. Maybe the newest orthopedic trauma society in the world. It was actually established by a small, very small group of surgeons. And as a brief, South Sudan as a country emerged from a protracted conflict that lasted for about half a century. And as a result of that conflict, there was actually a lack of basic infrastructure. Starting from road, electricity, water, and healthcare is actually one of the biggest, the ones with the biggest impact. We don't have proper healthcare infrastructure. So on gaining independence in 2011, there were two foreign trained orthopedic surgeons who decided to go back to South Sudan and establish the profession there. Next. Next. So the number increased from 2 in 2011 to 11 in 2021. And this is actually the group that established the society. Currently, we stand at 13 orthopedic surgeons. So we do have the common understanding that, that orthopedic care is a big problem in the country. We need to find ways to solve this problem. So based on that, we registered ourselves as an NGO because we wanted to be in the thick of the action, not to be just a professional body, but actually an NGO that can go out there in the field and do the work. Next. So these are our objectives, and you can see in bold that one of our main objectives is to enhance an equitable and quality access to orthopedic care among South Sudanese. And this is all focused on the concept of global surgery, that everyone has the right to have access to orthopedic care. So these are our core objectives that we're actually working on at the moment. Next. So without further ado, I'll go straight to my case presentation. So ankle fractures in general are relatively common. And as we know that it has bimodal distribution, where there is increased incidence in elderly osteoporotic patients, most of the time as a result of low energy fractures. And surprisingly, this has a mortality of 12-month mortality of about 11.9 to 27%, which is quite high for a fracture which is relatively benign. In the young patients, usually it results as a moderate energy twisting force, and these are usually easy fractures to deal with. Open reduction in internal fixation usually give very good results. The problem is that these fractures are challenging in the osteoporotic elderly patients because of a lot of risk factors, including poor bone quality, as well as if it presents late, as we will see in the case that we're going to discuss. So apart from ORIF, there is an option of using tibia talocalcaneal nail, which has gained a lot of interest recently, and mainly the focus of TTC nails is on ankle, difficult fractures such as ankle fracture dislocations and bad pylons in settings where they present late. It's also useful in the elderly with poor soft tissue or poor bone quality. These nails actually come in handy. Next. So our case is a 36 years old lady who presented to me 15 months after a left ankle fracture. And as is the case in many parts of South Sudan and in many parts of maybe sub-Saharan Africa, if I may say, the fracture was inappropriately managed by a traditional bone setter, and the patient presented with an ankle deformity, swelling, as well as pain on weight bearing. On examination, she had limited ankle dorsiflexion. Next. So these are the X-rays. I'm sure a lot of you, especially those ones from Africa, see these kinds of X-rays. This is this was a case of a trimax fracture dislocation. We can see that there is a posterolateral talus shift, and we can see that there is already some degree of union. So it's a case of malunion with also degenerative changes, as we can see from the osteophytes on the anterior ankle. Next. So we talked with the patient, and she understood that we're going to fuse the joint because it's a late presentation and the patient already had osteoarthritis. And for us to get good function, we really needed to fuse the joint. So we took the patient to the theater, and through an anterior approach, we were able to approach the ankle joint, take a chip of bone with cartilage. This enabled us to achieve the reduction that we wanted. For some people, you can fix it. You can fix the reduction provisionally with some K wires before we advance the nail, but that's optional. For us, we just decided to proceed to hold the reduction manually and then advance the nail. So in this case, we use sine nail. Many of you are familiar with sine nails. There are a few important technical points, especially using this specific type of implant, because we know that the sine nail has it was designed for fractures of the tibia. So it has that typical bend on the nail that is typical of tibial fractures. But the nail is being used universally for fractures of the femur, and in this case for ankle fusions, and probably maybe for ankle fractures. So the entry point, as with many TCC nails, is we just draw a line along the medial and lateral malleoli towards the plantar aspect of the foot, and then on the medial lateral plane, we just go in the middle. Some people say that you have to go slightly lateral just to try to avoid injury to the medial plantar nerve. But in this case, we just went straight on, and then we made our stab incision all the way to the calcaneum, and then using an awl, we access the calcaneum, and then the sine nail set has a 4 millimeter drill bit. So in our case, we decided to use that. Some people may use K wires, but we use a drill bit, and then we drill from the plantar aspect of the foot, going towards the talus, and through the area through the anterior approach where we did the joint preparation. We just ensured that our drill bit exits right in the middle of the talus. This is very important for the joint alignment in the fusion. So we have to make sure that we hold the reduction in place, and then the drill bit exits at the center of the talus and then goes all the way to the canal. Some people may use fluoroscopy for this, but we know that in most resource-limited settings there's no fluoroscopy, and that's actually the utility of sine nail. That you don't need to use fluoroscopy. But if you have to do it, then you can use fluoroscopy to make sure that your reduction is achieved. Next. So while we're maintaining the reduction, that is, the foot will be in plantigrade with about 5 degrees of hindfoot valgus. We inserted a larger drill bit, which is in this case a step drill in the sine nail set. It's just a larger drill bit, and then we just followed the same track all the way to the tibial marrow, and then after that we graduated to a larger diameter, hand reamers that also are there in the sine nail set, and then we inserted the nail. And this is an important point because in the tibia in general, we lock sine nail from medial to lateral. So in this case, when we're inserting the nail, we had to ensure that our locking also goes from medial to lateral to try to avoid the soft tissue that are in the lateral aspect of the leg. And in this case, we had the option of either placing the ball on the proximal nail. Either the ball should be facing apex anterior or apex posterior. We think that it's very important for the ball to be facing apex anterior, just to ensure that we maintain that plantigrade foot. Because sometimes, for example, if the ball is apex anterior, then we may have an equinus posture for the foot. Next. So this is These are the post-operative X-rays, and we can see that we're able to maintain good alignment, try to reduce joint, maintain good alignment, and yeah. So you can see that the locking is from the medial side to the lateral side. Next. So post-operative recovery, we asked the patient to weight bear as tolerated. She started working on a frame, a few days after surgery, and then graduated to crutches. And on follow-up at 3 months post-operative, the patient was actually weight bearing without crutches. So she was able to get up early enough. Next. So these are the 1 year post-fusion X-rays. Never mind about the screw, which is outside the slot. This happens a lot with, sometimes it happens with sign nails, especially when the target arm is, has worked for a long time. So sometimes we miss the screw. But it's good that at least we had both proximal and distal interlocking, and we can see that at 1 year post-fusion, we have a very nice fusion. And I would just like you to notice on the entry point, it's one of the screws. The screw which was missing actually was going to go through the subtalar joint, and that's a point that we're going to talk about later. Next. So let's talk about the advantages of TTC in general. We all know that these are minimally invasive methods, and it's very useful, especially for the elderly patient. Who have very poor healing capacity, or for fractures that you may think that may delay in healing. So it improves the chance of the fracture healing, or for example the arthrodesis for healing. It's also very robust and allows early, sometimes immediate weight bearing. For elderly who undergo a normal ORIF or regular ORIF, we saw that the 12-month mortality was about 12%. And most of this is because of pressure sores, DVT, and orthostatic pneumonia. So for these elderly patients who, for example, have acute ankle fractures that want them to get up and running as soon as possible, TTC nail is good. If we put an ORIF, for example, usually the patient stays for 6 weeks, non-weight bearing, and then maybe after that they start weight bearing. So any period of non-weight bearing in elderly could be detrimental. So that's an advantage for TTC, that it allows them to get up and moving as soon as possible. And some studies report a superior outcome compared to ORIF in the elderly and osteoporotic patients. And in this instance, we are talking about a trade-off between function and healing, because when we insert a TTC nail, we're going to violate both the subtalar and ankle joint, especially in someone who only has an acute ankle fracture. Violating these joints may sound counterintuitive, but for someone who has maybe 5 years or 10 years to live, you may try to balance between the risk of getting osteoarthritis and getting the patient up and moving early. Disadvantages: violation of the joints, and we know that the anatomic reduction would be less superior compared to ORIF. Next. Excuse me. So let's talk specifically about using sign nail as a TTC. The pros is that sign nail is readily available and it's donated. So in many countries, it's actually free of charge. So this is a very important point, because a lot of people do not have resources to purchase orthopedic implants. A lot of facilities do not have fluoroscopy, so sign nail does not use fluoroscopy, and that's a very important advantage in resource limited setting. But we have a few disadvantages. We talked about proximal bend on the nail, and for us who have seen conventional or dedicated TTC nails, they're usually straight. They do not have that bend. Some of the nails actually have a slight bend to allow a slightly lateral entry point. So in the case of sign nail with the proximal bend, I think one of a technique that we use is that we make sure that the bend is apex posterior, and then try to place the foot on slight equinus, because when the nail goes inside all the way, it may kick the foot a little bit into dorsiflexion. Sorry. And regarding, like, we don't have a lot of options regarding locking. Side nail is usually medial to lateral locking. So locking on the proximal part, I mean, locking on the tibia is not a problem, but now the issue is locking at the level of the foot. When you're locking from medial to lateral, we encounter the neurovascular bundle. So that's very important for us to protect this while we're doing locking. The other issue was that if you could recall the X-ray, like one of the screws which is locking is actually aimed at, I think, at the level of the subtalar joint. So we have to understand how deep should we sink the nail to be able to lock the nail, to avoid the subtalar joint while locking. The other issue is that when locking from medial to lateral, we don't have enough bone stock at the level of the calcaneum, for example, to hold the screws. And we know that some dedicated TTC nail actually they have locking which is going from posterior to anterior. So that's one of the issues. Next. So there's that question of joint preparation in TTC. There is a lot of controversy in this, but many people with fresh ankle fractures who may need TTC nail, sometimes they put the nail without preparing the joint. So if the aim is to do fusion, just like this case, we may prepare the joint. But if the aim is to treat an ankle fracture in an elderly osteoporotic patient, when you don't have locking plates, or when the soft tissue is not good enough, then you can just go ahead and fix the fracture without having to prepare the joint. This also applies, for example, for difficult pelvic fractures. But again, there's no robust data on the functional outcome when you do joint preparation or not. Next. Next slide, please. So conclusion, TTC nails are viable options for neglected ankle fractures and severely comminuted pilon fractures. They are excellent options for elderly osteoporotic patients with precarious soft tissue who want to return back to function early. Why? Because you need to get them up and running as soon as possible. You can prepare the joint. You can decide not to prepare the joint. We don't have long-term outcome studies that can give us, guide us on this aspect. Side nail can be used with a few technical adjustments, and we're still in a learning process. There are a lot of techniques that we need to adjust our techniques when we're applying side nail for TTC nail. Next. Next. So these are a few references, and I want to show the last picture on the slide. Next. So this picture actually provides a summary of what we do in South Sudan Orthopedics and Trauma Society. So this was during one of the outreaches, and we can see that while we're treating the patients, we're also making sure that medical students get to be taught. Not only medical students, we do the teaching in the theater. We try to make sure that we combine teaching and treating the patients at the same time. Thank you very much. That's all for me.
Thank you so much, Brian. That was a fascinating case. And I think you highlighted a lot of very interesting topics here. Neglected trauma, managing it with limited resources, and the work that you do to train and educate the next generation so that you can build capacity locally in South Sudan. Really remarkable. Thank you so much for that case. I want to keep track of time here a little bit, but I do want to pause for a moment and just invite a few folks to make some comments. I know that, we have some foot and ankle surgeons from University of Missouri on the line, and Dr. Mohammed Fadel is very experienced in lower limb reconstruction. I'm sure he has some comments. So maybe I'll hand it over first to Dr. Mohammed Fadel. Can you just in very briefly just give us a few comments on this case?
Oh, it is great. Thank you so much. It is a very nice case and confronted with many complications. You solved a big problem with a simple maneuver. It is very good for such patients. especially if you have the resources, as you mentioned. Cyan nail is a good option. And also the difficulty that it is not designed well for fitting this retrograde TTC. So you did a good job, and you may be in need for some assessment for the maybe some sort of plantar flexion of the ankle or the forefoot. So you may be confronted with some difficulty or some complaint of the patient. I hope that you be ready for some maybe complain of them, and you may safeguard this by doing some sort of a custom made or to some extent high heel to some extent, and she's female, and I think no problem to have such a high heel. Also have some sort of rocker bottom in the midfoot slightly. It will not be bad, but will solve the problem if she asked for doing something for procurvatum or recurvatum problems. But as globally, it is a very nice and very good, and you cut short for many difficulties had been caused by bone setters. Thank you and congratulations for this outcome.
Thanks, Dr. Fadil. I also see that we have Dr. David Frumberg on the line. David was the one who recorded the excellent presentation on managing pilon fractures. And I wonder, David, do you have any comments on this?
Yeah, I think to me, it's always the most remarkable thing to be able to get basically anatomic alignment without any fluoroscopy. And I think it's not an easy task. I mean, I was trained doing cases only with fluoroscopy, and I really rely on it. And so maybe my anatomy, my surface anatomy, and my understanding on how to get good starting points is significantly less than Dr. Madison. I mean, you saw in that case, the coronal alignment was perfect. The axial alignment was perfect. In the sagittal plane, a little bit anteriorly translated, but that just doesn't matter in the end. And you were able to salvage this person's total function. I was just so impressed by it. And actually, I think that missed screw distally is not as big of a problem as you may think, because it'll give you a little bit more stability regardless. And we know that there's a lot of evidence that preparing the subtalar joint, a lot of people don't even do it. Just crossing the subtalar joint with the nail, some believe causes enough stiffness that you don't even have to open it and prep it when you're doing a true TTC fusion. So I think you are going to get some stability regardless of whether that screw is interlocked and whether you compress that joint at all. But I think that if you can master a TTC for a case like this, where the soft tissues are sometimes a little bit contracted and it's hard to get yourself medialized and even anterior, then you can use this technique to salvage a lot of legs. Yeah, thanks for inviting me. I really enjoyed the case presentation, Dr. Madison.
Yeah, it was fantastic. I guess Dr. Kafuri and Dr. Schwesser from University of Missouri, I wonder if either of you have any comments about this case as well?
Yeah, I mean, again, I'm going to echo what was said earlier. Like, your reduction was great for not having fluoroscopy. You know, we rely heavily on fluoroscopy here to get our starting points and our reductions. So, you know, great job on that, especially when you have a bend on the nail. There are some nails out there that have a bend. There's a nail that's posterior, you know, it's posteriorly based, and another one that's laterally based where you modify your start site. But that was a great job. You know, some other things that you could consider from an approach standpoint. I've gotten away from the direct anterior approach. There was there's been some papers out of Canada and other centers on angiosomes, and that an anteromedial, there's a modified anteromedial approach that is a little more soft tissue friendly if you're ever worried about, you know, an elderly or diabetic and you really want to do an approach. Oftentimes I'll do a direct lateral and just do a fibular osteotomy, because if they have a wound breakdown, I think that is a little easier from a soft tissue coverage standpoint. And then you were talking about prepping the joint versus not. And I think that that's got to be patient specific. So a lot of times in diabetics, poorly controlled diabetics or an elderly, I will not prep the joint. I will just place the nail, reduce the fracture and place the nail. And then at 4 to 6 months, once their fracture's healed, I discuss with them if they want the nail out. And some do because they have a little bit of pain or they want.
Kyle, are you there with us? I think we may have lost you. Are you guys hearing me?
I can hear you.
You know,
Okay.
if it's a low demand patient where the nail's only going to be in for like, 5 to 10 years, it's probably not a big deal. But in a 20-year-old who's going to be really active, and you get 20 or 30 years out and you have prepped the joint, they're going to probably have they're going to have some discomfort and some problems. And so that's kind of that's my thoughts. And if anybody else wants to comment on when they decide to prep the joint or not, that's kind of my algorithm. But great job. Seriously, that was great.
Great points, Kyle. Yeah, I agree. So typically when I've done my TTC fusions, I will do a direct lateral approach and do a fibular osteotomy and use that as bone graft. I guess the one question I had for Brian is you notice in your case, the subtalar joint is obviously not fused, despite maybe prepping it with the reamers and that sort of thing and hoping that the posterior facet maybe is fused. But, you don't have that locking screw there. Did you talk a little bit about removing this nail for this patient if she were to ever become symptomatic?
Yeah, I think last time I saw the patient, she was already, complaining of some pain, which I thought was not coming from the ankle joint because it's already fused. So I think we discussed removing the nail. I thought maybe the pain was at the level of subtalar joint because there was a little bit of discomfort on foot inversion, reversion. So I think we are planning to get the nail out.
Yeah. Okay, that makes sense. Yeah, in some of these neglected ankle fractures I've taken care of in Malawi, we typically do a tibia-talar fusion just with like large screws. But of course, the bone quality is so poor, we often have to cast the patients and we can't let them weight bear. So I think your solution is a really nice one. And I'll keep that in mind next time I have to deal with this. Okay, so for the purposes of time, unfortunately, let's move on. The next case, next slide, please, Yak. Next case will be by Dr. Omojok from South Sudan. So Dr. Omojok, please take it away.
Hello, everyone again. I'm Dr. Omojok Bachai from Juba Military Hospital here in South Sudan. I'm just going to take you through few cases that we encountered here in our facility. Next slide, please. This is my biography. I think you can read it because of time. Next slide. Nothing to disclose and no conflict of interest. Okay. For us here in South Sudan, sometimes in your clinic, you might face a case like this, and then they disappear. Next. And then they came later on with something like this. So you imagine this is a kid, 13 or 14 years old, and the degree of disability that he's going to get in his life because of most of them, they used to come and then they disappear, going to the traditional bone setters because of so many reasons. Some of them believe in traditional bone setters, and some of them, they cannot afford orthopedic surgical procedures. And for others, the idea of having a metal inside their body is a bit, they don't like it. That is why most of the people used to go to traditional bone setters. Next. So we used to ask ourselves, why do our people go there? Next, yeah. Next. So South Sudan has been downgraded from a middle-income country to a very, very, very low-income country with an estimated population of a bit more than 12 million people. That 12 million is only served by the orthopedic surgeon. Out of 15 South Sudanese orthopedic surgeons, some of them are still abroad outside the country. They're practicing somewhere else. These 13 orthopedic surgeons are working in a very, very, very limited resources, and they are all inside the capital of South Sudan. And imagine these 12 million people are divided among 10 states. So many people are very, very far away from the capital. It is very hard for them to reach to get a proper orthopedic care in the periphery. So they have to come to the capital here. So that is very expensive. They cannot afford it most of the time. So they go for those traditional born setups. The country went through a tragic wars, communal crisis, and cattle raiding. So we have so many cases of firearm injuries, and recently with the modernization after secession from the north, there are a lot of road traffic accidents because of these poor roads we are having here. All that led to many cases be treated by these traditional born setters, and later they present to our facilities with much complications. Most of the complications that we encounter are, next slide, please. The most common presenting lower extremity fracture complications for us here are malunion, non-union, chronic osteomyelitis sometimes, and ischemia due to very tight bandage that they used to put there. So I'm going to take you through 3 cases that we encountered here and how do we manage it. Next. This is a 50-year-old male who was involved in road traffic accident 2 years prior to the admission, presenting with limping and abnormal movement on the right leg. He's not diabetic or hypertensive. Initial assessment, the patient is in good condition with abnormal movement at the distal end of the femur and a slightly stiff knee joint. Flexion extension degree is from 40 to 120 degrees. Next. X-ray showed a not united fracture distal femur with a shared fracture line and overlap of ends. This is the X-ray. You see here it's a bit hard to tell whether it is a malunion or an non-union, but there is a clear gap between the two fracture ends, and there is a big overlap of the two ends. So we decided to take him for operations after consulting the patient. We did the necessary investigation because some of these patients, sometimes they used to lose a lot of blood during the time of operation. Next. Intraoperatively, we approach the distal femur anteriorly because we are planning to insert a retrograde nail, and we deploy between the two fragments. We remove all the soft tissue and the pseudo joint. Then we reduce the two ends, open the canal, and inserted the retrograde IM nail. This is the immediate postoperative X-ray. We assessed the patient postoperatively. He was able to ambulate with the Zimmer frame. He was a bit on pain, but the leg links was a bit restored. Next. I will go immediately into the second case. 45 years old male presented with severe deformity and shortening of the left leg for more than 20 years. This is an athlete, a goalkeeper, who used to play football, and he got injured during one of the matches, and they throw him in the hospital, and he couldn't afford for surgery. So he left for traditional bone setters. But you will see the X-ray. Even I don't think they follow the instruction of the traditional bone setters, because these traditional bone setters sometimes, though for us they are doing a bad management, but sometimes end up with a good outcome. But this is a totally different case. The patient was evaluated, and local examination of the leg showed some valgus deformity of the left distal third tibia and fibula with posterior medial angulation, and there is some degree of shortening. Next slide. So this is the image and the X-ray of the patient. This is what I meant when I said that traditional bone setters, they used to apply some materials that will keep the limb aligned. Our fear most of the times is the limb ischemia or non-union, but this is a gross, too much deformity. I think this case was neglected and he didn't get any attention at all. Next slide. So we planned him for corrective osteotomy, and as I said, there was a bit shortening, but was due to angulation. For osteotomies, if you use a closing wedge osteotomy, it will shorten the limb. Open wedge osteotomy sometimes used to lengthen the limb. After evaluating these patients intraoperatively, we found that closing wedge osteotomy will give few centimeters, because we're going to correct the angulation and the leg links will be restored. Intraoperatively, the tibia was approached anteriorly and closed wedge osteotomy was done. Then an interlocking nail, IM nail, sign nail was inserted. This is the postoperative X-ray of what we did. Distally here, we inserted only one screw because the other screw was loose. We have to remove it. Leg links discrepancy was not there in the post-operative evaluation, and the patient was able to ambulate, and he's still on follow-up. Next slide. The third case is a 56 years old male. It's a sternal fractured distal femur after a fall 1 week prior to the admission. When we evaluated the patient, there was a swelling at the proximal aspect of the thigh. And from the history, he told us that he had a fracture before, which was also mismanaged by a traditional bone setter. General examination of the patient, he was stable and nothing to comment about. Leg links discrepancy was about 4 centimeters. Next slide. Next. When we did an X-ray there was a fresh new fracture at the distal aspect of the femur, and also there was an old malunited fracture at the proximal aspect. Can you show the next? Next. Yeah, this is the X-ray. You can see here, this is the fracture, the fresh fracture of the distal femur. And this is the malunited all fracture. This is a case which is, how will you manage it? This is the first question up into our mind. Do we have to correct the all fracture, or just deal with deal with the current fracture? We took him in and we decided to do osteotomy for the all fracture and put the whole limb in alignment and insert an iron nail. And this is next. This was the final outcome after the surgery. The distal fracture has been reduced, and there is a good alignment in the proximal all malunited fracture. Next. So, postoperatively, the patient was mobilized on Zimmer frame on non-weight bearing. There was some sort of leg length discrepancy about 2 centimeters, but he can tolerate. But I think we managed to relieve him from the disability he was having before. Next. Next slide, please. So this is a few of so many cases that we are facing every day here in South Sudan. Because of the war, so many people has been injured long time ago, and now they hear that there are some orthopedic surgeons who are doing the job in the country. So they show up for a proper management and proper care, because most of these people are manual workers or soldiers who has become disabled because of this malunion or non-union. The last slide, I just put it. This is a case who came to me like 2 weeks ago, and you can see that there is a malunited fracture of the distal femur, but I think it was a segmental fracture. You can see the condyles here are fractured also and malunited. His main problem was the movement of the knee. You can see the patella is blocking the extension and the flexion of the joint. So I just put that slide so we can brainstorm ourselves what to do for such a case. And thank you.
Dr. Omojok, thank you so much. Those were all fascinating cases, all 4, including this last one. I wanted to give a shout out to Dr. Malik Diallo from Burkina Faso, who has published a case series of neglected epiphyseal fractures of the distal femur in children. In Burkina Faso, from what I understand from Dr. Malik, they see a lot of traditional bone setter related complications. And he published a wonderful case series of cases that he managed there, where he does open reductions, pinning, and casting for those kids, and they end up doing quite well. Some of them are neglected for a long time. So I encourage everybody to take a look at his article. I would also like to give a shout out to Dr. Keba Marena, who is a principal investigator, part of a study called BOSAD. It's the Bone Setter Associated Disability Study. Dr. Ephraim Gebrehana is also part of that study, but I don't think he's on the line yet. It's a study that's between Gambia and Ethiopia, looking at traditional bone setter associated complications. So Keba, if you're on the line, I just wanted maybe if you could share a few words, your perspective from West Africa, from how you've managed similar sort of situations and what you think of the cases that Dr. Omojok just presented.
Hi, Kieran. Hi, everyone. Thanks for having me on the line. Great presentations. I mean, if one of us from the Gambia was to give similar, we'd see very similar cases. It's a very similar situation that we have with a huge number of our patients going to bone setters, either before coming to see us or even after being proposed treatment. And we almost do as many non-union, malunion type surgeries as we do fresh fractures with the long bones, especially tibia and femur. So it's a very similar situation. I noticed in the comments some people are talking about the lack of surgeons maybe being the issue or lack of awareness. Certainly in Gambia, we find that it sort of cuts across the board with regards to educational status, financial status, etc. It's just a deep-seated belief, and it's not really it's not because of lack of services. Although we are finding a bit of an improvement now that we are doing more surgeries, that a few people are turning towards us. But I think it's always going to be there. It's always going to be a bit of a battle, and it's just trying to see how we can salvage some of these before they turn into issues. So helping the bone setters know what their limitations are. But certainly, I mean, the cases are always very challenging. They are somewhat fun to do in a way, because you get to bring someone back to their level of function after years of disability, and that does raise the profile of the orthopedic surgeon in the country to some degree, and helps prevent some of them going to bone setters. But definitely very challenging. And the sign nail, again, with us in the Gambia is our friend. We use it for almost all of our non-union cases. And it tends to work very well, either the fin or the sign. And it's just trying to pick your battles with how you approach these. And I mean, all those cases, you know, that were presented are very, very big challenges for most of us. And yeah, there's no right or wrong answers to how you go about it, really. It's the outcome at the end of the day that tends to matter.
Thanks, Kemba. And Daniela Scuto, who practices in rural Kenya, I'm sure that you see cases similar to this. Would you like to comment at all?
Hi, Kiran. Hello, everybody. Yes, I would say that Samburu County is very much has a lot of similar point to South Sudan. Both are pastoralists, lots of gun, lot of issue. I have to say, I really like the slide that he put when he said the question mark, why? Why do people go to the traditional bone setter? That's a very good question. And if I have to share my experience, is most of the time is just like there is no other option, because Samburu, like South Sudan, the issue of transport and the roads are so tough, so difficult. The transport also, the cost of transport to reach maybe a facility is also extremely high to reach these places. Security also wise is sometimes you say, well, if I have to go to the hospital and get a bullet on the way, is it really worth it for me to go to the hospital? So sometimes that's actually the only option. So one of the answers to why is because that's the only option for these people. And also the payment sometimes, you know, traditional bone settler, they can be paid. They're not cheap. Huh? It's not that they do for free. Actually, they're quite expensive, but they can be paid in animal. So in Samburu, you get almost one full goat for being traditional attended by them. And another thing, and is traditional bone setter, not everything that the traditional bone setter does is bad, if I have to be honest. Sometimes they do good stuff. I've seen it. They are quite good in alignment of the limbs. They are very good in stability. They are very fantastic in finding a way to stabilize the bone. So they have some good skill in actually treating trauma. They are not so good in compression. Sometimes they tight too much. So actually we get a lot of issue becoming with ischemia. So somehow in the back of my mind, I have this kind of dream of idea that the traditional bone setter can one day be part of the workforce of a trauma team of hardship area like Samburu or like I think South Sudan, with somehow a way of a training or somehow a combining forces between medical, healthcare, and traditional. I think they could be, if well directed, support, especially in an area like we saw the map that he showed, where actually the health force is so little compared to the big and huge population and the burden of trauma.
Thanks, Daniele. Yeah, good points. So our colleagues in Nigeria have written quite extensively about traditional bone setters, and there are essentially two schools of thought. One, that these practitioners should be completely eradicated from practice because they cause so many horrible complications. Granted, we as orthopedic surgeons are probably biased because we see the complications much more so than the success stories. And then the other school of thought is that we should be training traditional bone setters to be part of the workforce to extend the reach of orthopedic care, especially to rural people. But as Keba mentioned, many people go to see traditional bone setters who aren't just from rural areas. They are educated and it's part of the community. It's part of their culture. That's the reason that they seek traditional bone setters. The payment may be easier. There are many, many reasons why traditional bone setters are sort of here to stay. So I think we need to recognize that. The team in Ethiopia and the team in Gambia are doing a fantastic job understanding the perspectives of patients and trying to find ways that we could intervene to reduce traditional bone setter associated complications. There are also others. There's a team of surgeons led by a group in Kumasi by Dominique Kunedu-Yeboah that's doing a fantastic study trying to train traditional bone setters and decrease complications that way. There's also a team in Tanzania working with the Global Surgery Foundation that has started working on training traditional bone setters. So, it's a controversial topic, but I think it's very fascinating. Just before we go to break, I wanted to give a chance for Dr. Deepa Bose, if she's on the line, to maybe comment, given her experience as a limb reconstructive surgeon. I wonder what your comments may be, especially about case 2 and case 3. Deepa, are you there?
I'm here, Kieran. Can you hear me?
I can, yeah. Thank you so much.
No, not at all. I was fascinated by the cases. They're absolutely brilliant. And the outcome that has been achieved is really amazing. I think, it just shows how following basic principles, you can achieve really good results without any high-tech equipment. So, it's really very impressive. But I'm also fascinated by the talk on traditional bone setters. And I think that if they can be somehow brought into the community of orthopedics, that would be the best possible thing.
Yeah, agreed. Thanks, Deepa. Appreciate that. And then we also have Jack Wickstead on the line. Jack, I don't know if you've seen any traditional bone setter associated complications before, but you certainly have dealt with a lot of complex limb reconstruction. I wonder, from your perspective at Harvard, what do you think of these cases? Jack, you there? All right, well, that's fine. Anybody else have any comments before we go to the break?
I would like to make a comment.
Please.
So first, thank you for inviting me to attend this incredible meeting today. It's fascinating, as has been said. I would like to say the cases are amazing and the solutions outstanding. And as has been said, using principles is really the way to deal with those problems. Just to give you a little bit of background about myself, I was trained and worked for 20 years in Brazil, in Latin America. And I got to travel all around, not only Brazil, but Latin America. And I got to operate so many times without a fluoroscopy. So I kind of understand the pain of getting alignment and getting things restored without having infrastructure. And what I could identify in those places was basically either patients don't have access to healthcare, as has been said, because it's too far away or because they cannot afford, or even surgeons don't have access to hardware. So then you have a combination of both, and it makes it really hard. So this is why initiatives like those are so important, so we can align the ideas and we can include people that need more education in order to provide them support and help them to be part of the community. As has been said, my understanding is that including the bone setters in the context of orthopedic trauma would be something beneficial in order to improve communication, improve patient care, improve outcomes. Regards the outcomes that have been presented, they are outstanding. Also in the setting where you don't have a lot of infrastructure available. And also it teaches us that sometimes the goals are a little different when you're seeking for just preserving the limb, just preserving the ability of the individual to walk and to be functional and to provide the family. So sometimes the goals, when you go to some areas where people come with significant shortening, significant deformities, is just to provide them the ability to come back to life. And this is such an amazing work that has been done, and I'm very impressed. Thank you for the opportunity to be part of this conference. Thank you.
Thank you, Dr. Kafoury, for joining us and bringing that perspective. That's really great. And just for everybody's information, we are planning on doing some more teaching specifically to improve capacity for frontline health workers and potentially people who are not orthopedic surgeons to help refer these complex cases earlier. So I'll be in touch about that. Sorry, any more comments before we go to the break?
I just have one quick comment. I posted a link in the chat on just a technique on how to do a clamshell osteotomy. I don't know how many people are familiar with how to do that there, but for shaft malunions, it works really well, and I think it's pretty straightforward, and it allows for great correction without shortening. And then the other thing that you always want to consider is the soft tissue, right? How contract is the soft tissue? And do you need to do any releases there, especially around neurovascular bundles? But a clamshell osteotomy is a great option for those shaft malunions. So if you want to look at that link, I posted a free article in there on how to do it both in the femur and the tibia with different fixation techniques.
Thanks, Kyle. Appreciate that. All right. Well, for the purposes of time, let's take a 5-minute break before we launch into our second section, just so that everybody can take a break and get some water or whatever. And then we'll come back at 15 minutes past the hour to launch into session 2. Thank you, everybody.
Thank you. Oh, my goodness.
Thank you, everybody, for joining us. Really, really awesome cases.
5 or 15, Kiran?
Just 5 minutes, please, if that's okay.
Okay.
Just because we're running a little behind schedule.
Okay.
Thank you, Mohammed.
Welcome.
Roman, have you ever seen any cases like this before in your practice?
I was just going to comment, just Thursday, I had a patient that was in a motorcycle crash in Nigeria 4 years ago, and he has a 25-degree varus malunion of his distal femur with about 10 degrees of motion and about 10 centimeters of shortening.
Wow.
So we're going to do him in steps. We first did a manipulation and quadriceps plasty, got to 90 degrees and sampled his bone for possible latent infection. And then second step will be to correct his varus. I think that 2 things I'd like to maybe in the next session we should emphasize more. And this is a common area of problem. Those cases are really nice, and it's emphasizing the bone, right? And it's easy to understand. It's you show an X-ray. It's you can hone in on it. But as was just commented, it's the soft tissues that are often the hardest things to deal with and the most complicated. And if they're handled poorly, can lead to the biggest disaster. And balancing, the need for the bone to be straight and the soft tissue to be healthy is really, really important.
That's a really great point, Roman. Actually, Dr. Mohammed Fadel, who's on the line, he works in Egypt and does a lot of complex lower limb reconstruction. And I'm sure you and he would have a great conversation about that, because his case really does focus a lot on the soft tissue. And I think we have one of his cases coming up in the next session, so that should be really good. It's a whole bunch of firearm related cases as well, which is even more complicated dealing with soft tissues.
Right, and it'll really emphasize it because it's in the acute phase, but also in the delayed phase.
Reconstructive phase, yeah.
Really understanding what's going on with the soft tissue. How pliable is it going to be? And is the patient a smoker and a diabetic, or is he a healthy 45-year-old former soccer player? Those are very different scenarios and what that tissue will tolerate.
Totally. And do you need to do a gradual correction for the soft tissues as well? Not just for the bone.
Right. Yeah. And when do you? Well, I think the debate is, number one, the approach. Mm-hmm. Number two is acute versus a gradual correction.
Yeah.
When to apply those situations, and I decided on a case by case basis.
Yeah. But that's what you have available to you. Like a lot of these guys, Roman, it's either acute or nothing,
Yeah, I agree. And then when you do acute, what kind of accommodation do you make? If I'm going to do acute, I'm more likely to tolerate a lot more shortening, right?
Right.
Yeah.
But I also think that concept of you can't do any corrective osteotomy until you get your infection taken care of, is worth. Like they're dealing with bone setters who haven't been opened up, and they're clearly not infected malunions, but the infected non-union or malunion is you got to get
harder
on first,
Yeah.
And that's a big challenge in a lot of settings. I know at least in Malawi, we don't really have access to bone cement or antibiotics, that sort of stuff.
Right. So even just getting rid of osteo is impossible.
Yeah, so it's a real challenge.
These are just almost insurmountable problems, and you can make these things worse. As bad as a draining malunion is, you can make it worse.
Yeah, what's worse than an infected malunion is an infected non-union,
right?
Or
an infected amputation.
Yeah.
Yeah, true. Yeah, I thought case number 2 that Dr. Omojok presented was really interesting. Where he had quite a lot of angulation there, and did it in a single stage, to bring it out to length. Obviously, I had to do a closing osteotomy in order to, deal with the soft tissues. I'm sure that was part of it. That was one question I was going to ask, but just we're on break now.
Yeah, that skin looked pretty adherent.
Questions, imply that there was any issues here, but it's always hard to know what happens to these if you have no follow-up,
That's a big challenge. Yeah. And I think using frames and doing gradual correction is really hard when people live in rural areas. I'm sure Daniele and Dr. Omojok and Dr. Keba Marina from Gambia can do that. But we're getting close to the 15-minute mark. So if anybody's hearing me, just everybody please come back to the stage. We'll give everybody a minute. We'll get started with the next section.
Really quickly,
thanks for the lively discussion even during the break, Roman and Jack. Appreciate it.
Hey, Kieran. Just want to let you know I'm just going to switch sliding, controlling the slides with Phil. Because we have an updated slide.
Okay.
Marcella.
Great. Now is the perfect moment. Go for it.
Okay. So Phil is there. I think we might be sharing now. And then we'll switch back to the big presentation after this.
Okay, wonderful. For everybody who's back already, thank you so much for joining us again for the second session. We're running a little bit behind schedule, so I appreciate everybody's patience. I mean, the cases are so good, it's hard not to pause and really take them in. So from Kenya, we have Marcella Ryan Coker, who's originally from Sierra Leone, but is doing her training in Kenya and has also been trained in the UK. She's going to present a case of an isolated femur shaft fracture. Don't let the title fool you. It is actually quite a complicated case. So Marcella, thank you so much for joining us today. Please take it away.
Thank you, Dr. Kieran. Hi, everyone. So I am a second year ortho resident in Kenya. As Dr. Karen has said, I am originally from Sierra Leone, but currently I'm in Nairobi where I'm doing my training. So I will take you through a case of an isolated femur shaft fracture. It's not the typical complex body trauma case, but these are cases that we see all the time, and they pose a challenge. So we will quickly go through one of them. Next slide, please. So I have no financial disclosures or conflicts of interest. Next slide, please. Our patient is a 31-year-old man that presented to us about 12 hours post accident. He was a pedestrian that was hit by a speeding vehicle. He had been initially seen at a peripheral facility and then was referred to us after they made a diagnosis of a right femur fracture. Clinically, he had no signs of a compartment syndrome. He had no obvious focal neurovascular deficit. The skin was intact. The other systemic review were unremarkable. Next slide, please. So in A&E, we got AP and lateral view X-ray. Sorry, the images are not super clear, but we can see the fracture. So he had a reverse oblique subtract fracture with a mid-shaft femur fracture. Next slide, please. So we made a diagnosis of an A03-C2 fracture with a reverse oblique component and a spiral mid-shaft component. Next slide, please. So the initial management, we followed the ATLS approach. We employed the adjunct. We started him on analgesia for pain control. We ordered for some labs, and he got skeletal traction, and we continued with pain site care. So at this point, considering the components of the fracture, that he's a young active patient, the options that we had really were just deciding between two types of nails. So either a recon nail or a cephalomedullary nail, depending on the availability of the implant. Next slide, please. So in the end, we went with a recon nail. So day 14 was his admission. He was taken to theater. So on the right side, I've put our approach. We did supine positioning of the patient, the trochanteric entry point. We had image intensifier. Pre-op, we planned to open just the proximal fragment because we knew that the reduction of that would be quite challenging. But intra-op, we ended up opening both the proximal and distal fragments, and we fixed the fracture with a 10 by 420 long recon nail. So on the left of the slide, you could see the post-op image. Next slide, please. These are just some more images post-op. So the distal fracture was quite well reduced. The proximal fragment, not so much, because intra-op, it was very difficult to reduce it. So we got a better reduction for the distal compared to the proximal fracture. Next slide, please. So post-op, the plan was to continue him on analgesics and antibiotics for him to start partial weight bearing with 2 crutches on post-op day 1 and a wound dressing plan. He was discharged on post-op day 5. He was tolerating partial weight bearing well with crutches, and he was scheduled for follow-up in 4 weeks. Next slide, please. So some of the challenges we had with managing this case was it had to do mostly with the availability of the implants and theater space, which then meant that we had a delayed time to surgery. He got the surgery about 2 weeks post-admission, and there's this risk of loss to follow-up because it has been more than 4 weeks post his discharge and we haven't seen him in the clinic. So now we're wondering whether his full weight bearing, what's going on with the fracture, whether he'd present with some more complications at a later date. We don't know that. But yeah, these are some of the challenges that we had. Next slide, please. Some of the things that we could learn about this case has to do with the availability of resources. Okay, I understand that in low-risk settings like ours, this is a very complex problem. It's not very black and white, but I would love to hear from other surgeons about their experiences with how we can reduce the time to surgery, or how we can improve our follow-up rates for some of these patients. Next slide, please. Thank you. I'd like to acknowledge Dr. John Kinyo, who is a fifth-year ortho resident, and he helped me put this case together. Thanks.
Tough case, and thank you so much for presenting. I think encouraging registrars to present their tough cases and share and get feedback from the faculty is really what we're all about. So thank you so much for giving that case. It was a really good one for discussion. I think I'll start with Jack Wickstead. Do you have any tips and tricks for dealing with these segmental fractures, especially these subtroch ones? I think Marcella commented very nicely that unfortunately the subtroch fracture was a little bit in varus. The placement of your screws, they're a little bit proximal, so I do worry a little bit about cutout with the position of those screws there. But Jack, go ahead, take it away. Do you have any other comments?
Yeah, I have a question for Marcella as well. What she thinks are the systemic challenges for getting a patient like this into the OR, rapidly. The one comment I would make is that the reduction is easy in the first, few days. And if you've got a delay of a couple of weeks, you're making your own life so difficult because the reduction becomes that much more difficult. The other sort of comment I would make is there's no reason to try and do this in a percutaneous fashion. The proximal soft tissues around the hip are very tolerant to a big incision. We do this for a total hip replacement or for whatever reason. And my comment would be, if you have a subtroch like this, the best determinant for how it's going to turn out in the long run is how accurate your reduction is. And you will make your life a lot easier if you just make a big incision. And then you're not doing a percutaneous nailing, you're doing an open nailing. Make an incision as if you were doing a total hip replacement. You can see the entire trochanter. You can see the subtroch area. You can split the vastus. And you can get a clamp around the fracture to get that thing reduced because you're staring right at it. And then you're going to do your nail right through that same incision without, compromising on your reduction. This way you'll get good control over that proximal segment, which is hard to control, and you'll be able to see the fracture and put a clamp across it. But I'm curious as to what you think the systemic, barriers that you're facing in trying to get this patient to the OR in the first, 3 or 4 days.
That's a very complex question. I'll let Marcella answer, and then I'd like to have Keba Morena also comment on that same thing and how he would approach this, if you don't mind.
Thank you, Dr. Jen. So in my experience here in Nairobi, say for this patient, for example, one of the biggest challenges was with, does he have insurance? Will his insurance cover the procurement of the implant, or do they have to pay out of pocket, and how soon can they get the funds to pay out of pocket? So it mostly revolved around the cost of the implant, who's going to get it, how soon they can get it, and then how soon we can find a theater space for him.
Yeah, those systemic challenges vary between countries, but some of the same themes are always there. Keba, what do you think about this case? You do a lot of proximal femur non-unions, malunions, delayed presentations. What are your thoughts on this? Great points, Keba. Yeah, I mean, Marcelo, you had the opportunity here to use a cephalomedullary nail, which is fantastic. But a lot of our colleagues, including in South Sudan, don't have that, and they would use the sign nail with that lateral kind of tension band plate for these subtrokes. Perhaps you've seen that before, Marcella. Dr. Brian Madison, Dr. Omojok, from the South Sudanese perspective, would you like to add a few comments here?
Yeah, thank you. I think, thank you. That was a good case. And it highlights a challenge that we usually have. Sometimes we actually get these cases a couple of months after the fracture. So in our case, I think we'll do a sign nail. Of course, with sign nail, we'll have to open the fracture side, both proximal and distally. So it's going to depend on whether we're going to split the whole limb open or we do separate incisions. But one technique point when using a sign nail is that we can try to access it, piriformis entry, while making sure that we keep the fracture reduced while getting the entry point with an awl and rimming. We have to make sure that the fracture is reduced while rimming, because one big challenge is that we get the entry point and then rim the fracture while it's unreduced, then it will end up in varus. So I think the most important point is just to get a piriformis entry point with a sign nail, and it's not that bad.
That was a really good point that Dr. Brian Madison just made. You can't rely on your hardware to get your reduction. You need to reduce it, ream it in the right position, and then place the hardware. That was a really good point. And a piriformis entry can kind of help you prevent yourself from falling into that varus position. But nothing better than, as Jack and Keba said, just clamping it once you get the reduction right. So for the interest of time, I think we'll move on to the next case. Thank you, Marcella. That was really fascinating. More questions in the comments. If you guys want to put them in the chat, that's totally fine. Let's go to our next slide.
Okay.
While we wait for the slide, somebody wants to make
Just working on getting to the next slide here.
Okay.
Dr. Juf should be on the call now.
All right. So, from the Gambia. So Mariam, if you're there, please feel free to take the microphone.
I think her mic might be muted here.
Okay. Are we having technical difficulties with this one?
I'm working with her to unmute right now. I think she's just having a little difficulty unmuting.
Okay. All right. All right. We'll move on to the next for the time being.
Apologies, just making our way here to the next slide, to the next case while we work with Dr. Juf.
We're getting a preview of the case now. It's a tough one. Hopefully, Dr. Juf can give us a presentation so we can discuss it. All right, I think the next presentation that we have is going to be on firearm injuries. So once we get to that slide. All right, here we go. So Dr. Obur from South Sudan, please take it away if you're able to. Go ahead.
So I believe this is Dr. Uber.
Dr. Uber, are you there? Bit of a bad connection from your end, Dr. Omajok, I'm afraid.
Are you with us? I think he's asking for the slide to be progressed.
Oh, we can't really hear him at all. The signal is really bad.
Hello, yeah, can you hear us?
I'm presenting arm-related lower limb extremity. So next slide.
All right, that's coming through a little bit better. Go ahead, next slide, Yak.
Here we go. Could you see that, Dr. Ubar?
Next. You hear? Yes, I'm using Brian. I hope you guys can listen to me right now. So for the sake of time, let's just jump to the slide of the case. Yes, next please. All right, thank you. Here I'm presenting this 51 years old male presented to the with a gunshot or firearm to his thigh, and was diagnosed as open grade 3A left mid-shaft femur fractures. And so patient primarily was resuscitated as a ATLS protocol. As we know, in this type of injuries, usually patients dies because of bleeding. So we usually proceed with the C and then CABC's protocol. Next, please. Yes, next. Okay, as you can see here, this is the X-ray. Patient had a mid-shaft femur fractures, community type. For sure, the X-ray is not adequate, but we can see some return of bullet fragments within the soft tissue. Next, please. Next, please. Next slide. Okay, thank you. The team and I, we brought the patient on, and we agreed to go for a surgical debridement and intermedullary nail fixation. So basically, for surgical debridement, there is a two type of a philosophy. The old philosophy they used to do a radical, like a debridement, whereby they go for extensive extension of the edge of the wound. They take the necrotic tissues. But the new philosophy now, they already goes into more like a conservative management. So they saying that it's better to go for minimal surgical department, given that the idea or the information that a gunshot wound usually has a low risk infection, of less than 2%, and that's a little bit acceptable. So next slide. Next, please. Okay, so our patient was brought to the theater room, and we, for sure, he was given spinal anesthesia and 30-degree flexion of the knee. So we did just a minimal extension, minimal debridement of the soft tissue, and then we go at the end, we just irrigated with a reasonable amount of saline, and then we go for our normal route or the regular route for a retrograde nail femur, like 2 centimeter incision was made at the infrapatellar pool. Then next, please. We incise the patellar tendon. Next. Okay, so we choose the entry point to be at the middle of the intracondylar notch. For sure, we're not using a fluoroscopy. So if you are using fluoroscopy, we're going to say the lateral view should be with the extension of the plummetic line. But since we are not using that, we arrange the canal, and we have to make sure that our entry should be in line with the axis of the medullary canal for the fear of the varus valgus deformity later on. So we remit the canal until +2 from the desired nail size. Next, please. Okay, so we introduced the IM nail, proximal and distal screw were places, soft tissue we were able to close it primarily. So post-operatively, we wound care, antibiotic, pain control. Then we advise the patient for an non-weight viewing and for serial X-ray. But unfortunately, the same problem that we facing here is that the loss of the follow-up. So those patients usually came from the village. So once they have been surgery was done, so they travel back, and then we lose the connection and we lose the follow-up with them. So I totally lost the follow-up with this patient. I couldn't able to have a serial of X-rays or any other pictures. Next, please. Next, please. Next slide. Okay, so for the discussion part, when treating femur fractures, usually caused by gunshot, there is some other mechanical factors that should be really taken into account, like side of the fractures, along between the differences or other different side of fractures that usually happen because of the firearm. So shaft fractures may be treated either with retrograde or antegrade nail. It has a equal union rate of 85 up to 95%. And all complete comminuted fractures should be treated with IM nail. Next, please. Next. So the research have showed that there is no any difference or distinction between treating with IM nail and external fixator. And so they usually choose a intramedullary nail because it has better healing and better mobilizations on top of the external fixator. Next, please.
Sorry about the delay changing the slides. We're having some kind of technical difficulty, so sorry. Thank you for your patience while the slides change very slowly.
So the SING nail system is available, and in this resort limited settings, and we don't need fluoroscopy as said by my seniors. And for the backdraws of the using the SING nail, that I usually found it hard for me because I've trained in Alexandria, Egypt. We don't have SING nail system, but when I came to South Sudan, I have to be trained by a surgeon dedicated that using SING nail, and I was lucky enough to have seniors that trained me well in using SING nail. Thank you. Next slide. Next, please. Next slide. So in conclusion, a lower extremity. Yes, okay. In conclusion, there is a lower extremity gunshot treatment. They are complex. They are involved to take into account a number of factors based on the anatomic locations, the mechanical factors, and the infection concern. So the treatment range from non-operative or prophylactic fixation to intramedullary nail. So we have those type, like for example, complete unicortical fractures. So based on this tensile forces, we have to treat it with preventive fixations. Then all complete and comminuted fractures should be treated with IM nailing. Next, please. Next, please. Thank you for, yes, thank you. And I would like to give my thanks for this opportunity to share my cases. And thanks Olive again for this Oman Orthopedic Society again for this.
Thank you, Dr. Ubor. No, that was a tough case. I'd like to hand it over first to Dr. Roman Haida, who gave our lecture on firearm injuries. Roman, what do you think?
Well, first, Brian, that was a very nice presentation of a difficult case, and I think we need a little bit of nuance. I agree that the debate on how much to debride in gunshot injury is not a hard science, but is one that really needs careful consideration. We don't necessarily know what weapon at what distance was it fired, but we certainly know that in general, low velocity, handgun injuries, the degree of soft tissue injury, although the comminution may be great, is not so significant, as opposed to a military style weapon, AK-47, AR-15, something like that, high velocity, high energetics at close proximity, or a shotgun is going to cause a much worse soft tissue injury and a much higher risk of infection. And so you really since you never know the weapon, you have to treat the wound and assessing that wound very carefully to determine how much debridement of the muscle and possibly the bone needs to be is required. And so I can't say that certainly it'd be dangerous if you just said, well, it's a gunshot, it's going to be fine, and we'll just do a minimally invasive technique. Some of them you have to open up very widely, and you'll have a massive muscle injury with necrosis that needs to be debrided. That said, the second step is a good stabilization. And I can show you a number of cases that I've been consulted with from Ukraine that they've been treating with an external fixator, and those are very problematic. They don't have the stability. They rarely heal. They always go on to malunion, and so you magnify the problem. So if you can temporarily ex-fix if that's your setting, but an early conversion to an internal fixation technique, particularly a nail, is very, very beneficial. And I think you've demonstrated that with this case. Obviously, it'll be important to watch that down the road. One kind of thing to consider, and I'm not criticizing your reduction and fixation, but the more metaphyseal you are, and the nail doesn't control that segment very well, and it's very possible that although you'll get bony union, that you have not insignificant varus deformity. And so consideration of a blocking screw that will narrow the canal effectively around that nail in the distal segment can avoid that problem. So it's just a consideration, not a criticism, but I think it can fine tune and expand the abilities of a nail to treat these metaphyseal femur fractures.
Good point, Roman. I mean, yeah, if you look at the reduction, there was maybe a little bit of varus, but you have to keep in mind that this is often done without a C-arm. And so performing blocking screws is extremely difficult if you don't have C-arm.
Again, not a criticism. Just
No, of course. No, this is constructive and great conversation. So, Dr. Mapua, I think you're...
May I add a comment?
Please.
So thank you for sharing the case. Again, very challenging case. One thing I'd like to share, I don't know your thoughts about, it's just for discussion. Probably 30 years ago, or maybe close to that, in my hospital, we didn't have IM nails in South America because we didn't have locking nails. We had contour nails, but contour nails are not ideal for those fractures because you need to lock them. My mentor designed, before sign, my mentor designed a nail that could be locked without C-arm. It was a very ingenious development for South America. And with those nails, we were able to fix many of those fractures without C-arm. We would open a window on the lateral metaphyseal distal femur so we could see the nail inside of the canal, and we could see multiple holes inside of the nail, and we could guess where to lock the nail and get x-rays to know if we locked the nail or not. It's an interesting thing I can share with you. But one of the things we've done before, just for the sake of information and maybe to get feedback from the panel, we have used a lot of bridge plates. So in the setting when you don't have nails, or when you don't have C-arm, or when you don't have many resources, we have used long, broad 4 or 5 DCP plates to fix those or to bridge those fractures in a way that would be working like a kind of internal fixator. And yes, it's not going to be as effective as an intramedullary nail. It's not going to be biomechanically superior to an intramedullary nail, but it was a very decent way to do internal stabilization of the fracture, controlling length, controlling rotation, and getting screws above and below the fracture zone, and making sure that we could give the ability for the patient to move the knee and to mobilize the joints, even if you would have to have them getting like partial weight bearing, and being aware that this is a construct that's not going to compare biomechanically to an intramedullary nail. So I would like to hear the thoughts of the panel about if you don't have the infrastructure, if you don't have the implants, if you don't have the C-arm, but you have the patient. So if a bridge plate would be an acceptable option in cases like those, according to your perspectives.
Mauricio, I can say absolutely that stability that will be improved as opposed to traction or an external fixator is remarkable. You'll have to be a little more careful in your soft tissue technique and more careful about progression of weight bearing. But I think it's a very effective way. And the other thing I'd add is in particular cases, you may really even consider allowing for a certain amount of shortening to enhance the stability and promote the earlier weight bearing. Because then you have less implant failure. If you had to go in the spectrum, ideally, a rod is better than a plate, and that's better than an X-Fix, and that's better than traction.
And I appreciate your comments, and what you said about the technique is a critical thing. The way we did it, we never opened the fracture site. We open above and below the fracture site to slide the plate under the muscle. We could see where the plate would sit on the lateral cortex. So this is why the C-arm would not be absolutely necessary. So we would have a retractor to allow us to see where the plate was sitting proximal and distal to the fracture. And we would go with a very long plate, as long as we could. And the tricky portion was, if you'd like to get very proximal, you have to bend your plates to accommodate for the trochanteric area. If you go to the distal portion of the femur, you have also to bend some to accommodate for the curvature of the lateral condyle of the femur. But it was possible to do it this way. And I remember having kind of small templates, aluminum templates, that would allow me to see how much curvature I would need for the plate, so I could bend the plate outside of the surgical field, and I could slide my plate later on. So I remember doing those things in the early 90s when no nail was available. And yes, everything you said is absolutely correct. We don't have the same stability as a nail. You have to have a patient who has to understand or be compliant, which could be an issue sometimes. And yes, we've seen failures with early weight bearing in patients falling into varus or deformities because they ended up bearing weight too early and because the defect was too long and they ended up not healing. And the alternative then was just to revise the plate to another plate, because then you have a kind of soft callus now. It's a more stable situation and you can get it healed again. So just some ideas. Also, you don't have the issue with the pin tracks of the femur that can get infected, or you don't have the issue of the stiffness of the knee because you can allow the patients to move earlier. So just some comments about what we have experienced in the past. And I appreciate sharing. I mean, I'm really amazed by this conference. Thank you very much.
Those were great comments. I wanted to ask Dr. Mapour, if he's on the line, if he has any comments based on what Dr. Kaffouri and Dr. Haida have said. I don't know if these long, I assume, Dr. Kaffouri, you're talking about using locking plates, like a long locking plate.
As a matter of fact, when I use those, I use DCP plates. Only standard cortical screws were available in the 90s. But yes, if you have locking plates, it's an option too. But when I use those plates, I use 4.5s, and they were broad plates with alternated screws.
Yeah.
So they would not be in the same line.
Yeah.
Yeah, Kiran, I'd like to reemphasize that point. Right now, particularly here in the States, we all think, well, bridge plating automatically means that you have to use a locking construct. That's not true. Mm-hmm. You have to have a stable construct, and you can do that if you have good technique with even standard screws with a long enough plate. It does not rely on a locking screw. The smaller, shorter piece you have, then it's going to be harder to control that piece. But if you have a metadiaphyseal seal segment with 4, 5, 6 screws, you're going to screw holes, not necessarily screws. You're going to be okay.
Yeah,
I completely agree.
No, I think the point I was trying to make is locking technology is not always available. Brian, you're on the line. Anybody from South Sudan want to make any comments here before we move on to the next case by Dr. Fadel?
I keep my comments until I will start, because you are thinking as if all the firearm injuries are sterile and soft tissue is not traumatized, and we have a very nice, not comminuted, not sclerosed. So you usually would like to go through by internal fixation.
Yeah.
I think we ignore too much the fact of many cases. I think all our area indulging in these cases nowadays, while no internal fixation is possible at all.
Yeah. Well, Dr. Fadel, I think your case is great. We'll get to that in just a minute. Yeah, please go ahead. From South Sudan, comments.
Yes. Yes, can I come in?
Yeah, please go ahead.
Yeah. Yes, this is the. Yes, we have experience with most. Yes, this is. So we have so many cases presented with gunshot to our hospital, both military and Juba teaching hospital. One thing we need to put in mind when you want to shoot plate versus intramedullary nail is that issue of infection, because when you put the plate, when you open the fracture site, you have to do debridement, of course. So you use a lateral debridement, and then if you plate, there will be that high chance of infection compared to nail. So we have been trying to do some pure plate when we run out of intramedullary nails, but high infection compared to intramedullary nail. Only that we have published a paper on it. Commonly, we have tend to use intramedullary nail compared to plate. We talk of MIBO technique here in an open fracture, which is comminuted as a gunshot, is very challenging. You will not be able to do that unless you open all the fracture side, put a plate, reduce, and close the wound again. So again, I'm in agreement with allowed a little bit of shortening such that you have stability, because all those comminuted fragment around in the soft tissue, when you allowed a little bit of shortening, you'll bring all these pieces of
Dr. Mapur, I think we're having a little bit of an unstable connection from your side with the internet, so I think we lost the last bit of your comment, but I think your comments were very well received, except for the last sentence there. Just for the interest of time, since we're already at the top of the hour and we have a few more cases to go, Dr. Fadel, can you please take it away?
Thank you.
Thank you. Can we get his slides up, please, guys?
Oh, thank you. It's very good. Our topic today is about firearm injury. Please, slide. Slide, please. I'm honored and pleased to be here with you in one of the fantastic Harvard Global Orthopedic Collaborative projects. And it is an honor for me to present this in this meeting of SOTS, South Sudan's Orthopedic and Trauma Surgery Society. It is a very nice for me to be in touch with you, although we meet many times in Egyptian Orthopedic Association conferences and in Secret and all over the world in many conferences. But it is a very nice to be here in your land. Also to thank SONA Global, also the faculty, the fantastic faculty which enriched the meeting by many of ideas. Thank you for Brian and for his work, and also for Omoj. And many thanks for Kiran, the mainstay or the main corner of this activity, and for our friend Dr. Yak, who did a lot for this meeting. Also for the attendee, who I found that a very good and tremendous fellows from all over the country, and also from all over Africa or from all over the world. It is very nice for us to be in touch with a fantastic faculty from international group. Another slide, please. This is my greeting for you from Al-Mini University in the south of Cairo, 200 kilometers south. This is on lie aside the River Nile. Slide. Yes, looking for this, I think this is bypass many introduction. I did it, may solve the problem of the types of injury that had been confronted in the cases of firearm injury. I'm sorry that this happened, that as extended one of my lecture is not, but because of the short of time, I think it suits our condition now. This is a case of firearm injury or shot or gunshot injury, 24 years old, grade 3B open fracture, middle third, comminuted with bone and soft tissue loss, as we see here, horrible condition. Slide, please. Slide, please. Hello? Hello?
Yeah, we hear you, Dr. Fadel. Can we go to the
Okay.
next slide?
Did you move on, or?
I'm not sure if why we're not moving on. Can we move to the there we go. Yep.
Next.
Next.
Yes, this is what had been happened in cases that our friends Mauricio Kafuri and also our friend Romano and Kiran talk is to go in a hurry to the bride and even to approximate and do a conservative debridement, not a fully debridement, which is the questionable condition of these cases, which depend upon the condition or the type of the missile, if it is low energy or high energy or high velocity. All this is depend upon the penetration and the what is had been missed by some of our colleagues is the cavitation, which is cavity penetrating or going through the wound from one side to the other side. All this need to be excavated and should be debrided and should be closed if it is major enough to do this. If it is a case of low velocity, we may not in need for maybe an debridement or something like this. But if it is a mild or moderate velocity firearm, we can do assessment because it is serious, it is questionable, and we should look for the penetration and from the entry and from the exit, which usually the exit is more than the entry. And also there is associated soft tissue and also necrotic bone comminution inside the area of the bone and also the soft tissue outside. This is for my colleagues and for trainee. We should be in mind these questions that had been elaborated by you in previous discussion. Slide, please. This had been approximated by few suture. So is it right to approximate? Absolutely. In this condition, it is not right to approximate by any means. We should debride, generous debride, and leave it open. We have 5 or 7 days to do what we would like, but should not be closed at all. Slide, please. This is what happened. Slide again, please. It was prepared to do an external. So this has resulted in failure. And the aim of infection, subsidence and everything had been gone away. Slide, please. So we should do aggressive debridement again for the bone and soft, and it worsens, not be enough by conservative debridement. Slide, please. And so we are in need for usually to go for a temporary external fixator and look and think for the infection and the necrotic comminuted bone and soft tissue, and also if there is cavitation, if there is in and compartment, and doing what we would like to do. Slide, please. Slide, please. So the problem is the infection, not only the open fracture, the infection and the soft tissue defect. Slide, please. So we did very hard thinking of ourselves is to do a monolateral, giving the chance for doing a flap for covering of the debrided soft tissue. And also after this, slide please, following the debridement of the bone, we apply a flap. So this is rotation flap, help us to keep the soft tissue and with the bone itself inside. We just do debridement in a hurry and do monolateral fixture. Slide, please. After a polishing of all signs of infection, laboratory and clinically, slide, please. We are sure that everything is well. So we define this area as you see here in the middle third. Slide, please. This will be resected. Slide, please. Yes, after this, slide, please. Resection, slide, please. Underneath the cover of the flap. So we did here a high in the metaphyseal area, a corticotomy to make a very nice transportation along this area, which is long, around 17 centimeters. Slide, please. Slide, please. Again, please. This is the journey of 17 centimeters from up from the metaphyseal to go down to the docking site there. Slide, please. Slide, please. Slide, please. This is about to be reaching the docking site. Slide, please. The long journey. Slide, please. It takes around 9 months to have this, but all this area, as we find, the patient can go here and there, go for the bathroom, for going outside his door, going to do any activity, and this 7 centimeter regenerate. It is so weak to have a stand on it. If there is a nail or if there is a plate, whatever it would be, but under the control of Elizarov from all over, this circling maneuver of Elizarov and the trampoline effect and the elasticity of the stability, which is resilient for doing regeneration to be enforced and improving in callus formation. It is very nice to go here and there to move. Slide, please. Slide, please. Driving to the tissue of the regenerate area of the docking site, we do a bone graft to be sure that everything is well, and do dynamization, dismantling of the Elizarov gradually until we feel that we have 3 cortices in AP and lateral view. And at that time, we can say we may take over the Elizarov. Slide, please. Thank you.
Thank you very much. Thanks, Dr. Fadel. As usual, your cases are very complex, and you covered a lot of really important learning points for all the junior people on the call. Thank you for that. We have a few minutes before the break. I just wanted to leave it open to folks to make some comments on this one, especially Dr. Cook and Dr. Della Rocca. We haven't heard from you yet. I just wanted to maybe ask you guys if you had any comments on this case.
Yes.
Yeah. This is Della Rocca. First of all, thanks so much for having me here. It's a real pleasure and an honor to work with all of you. May I ask a question of the first presenter, Dr. Madison? Okay, I don't know whether he's on. My question may come from a standpoint of being naive about sign nailing, but one of the drawbacks that he mentioned was what I perceived from what it was being said was the difficulty in achieving training to use the sign nail, and I was curious as to what the barriers were to receiving this training, whether it's a lack of instructors or a lack of time or a lack of funding or a combination of all of that. Are there any perspectives that any of the panel can provide us for that? I'm sorry, were you all able to hear me?
I hear you, but
hear me?
I hear you.
Greg, I think if I'm hearing your question correctly, it's what are the limitations for teaching people sign nails? I think some of this is just a resource issue. These guys have to train in a setting where they can actually learn how to use the sign nail. If I'm understanding your question correctly.
Yeah, I mean that was the.
Kieran.
Yeah.
I'm really sorry, guys.
No worries, Brian. Yeah, go ahead, Jack. Sorry.
No, I just wanted to make a comment on the bone transport case. That's a beautiful case and a nice save. That's a very, technical and time intensive, resource intensive effort. And, I do those myself, and I look back on them and I think, every time I do one of these, I think I missed the opportunity to avoid that problem by making sure the patient didn't get infected at the beginning. And that's usually about flap coverage.
Right.
And it's usually flap coverage within 48 hours. So when I see those injuries, my main concern, particularly for our trainees, is not how badly the bone is or, doing anything with the bone. I don't care about put that in an X fix. My number one concern on those in the first 48 hours is coverage, because if we can get that thing covered within 48 hours, we're going to win. And if we don't get it covered within 48 hours, we're going to be spending two years doing bone transplant.
Right. I think, Dr. Fadel made that point very well, that, the initial attempt to try to reconstruct the soft tissues and not do a thorough debridement was, I think, what put this guy in a little bit of a hole. I guess my question, and also for Roman, is, go ahead, Jack, sorry.
Sorry, Kieran, I completely agree too. I would say the other comment is that they tried a rotational flap on that, and clearly, rotational flaps are going to be quite limited for the trainees who need to learn how to do flaps. I would suggest the ALT flap, the lateral thigh flap, is really fairly forgiving and technically less challenging than some of the other, free muscle flaps. And we've had quite good success with it in the tibia, and you can get huge amounts of coverage. So if you're going to learn one flap, learn how to harvest an ALT.
But that requires micro, doesn't it?
Yeah, I mean, it requires a lot of technical experience, and that just may not be available. Yeah.
So availability of microscopes is severely limited in most of these places. So it's really, really hard.
Yeah, really a challenge. Yeah.
Yeah, really hard. The other thing I wanted to comment on was the management of dead space. If you go in and you do a big resection of all this necrotic bone and necrotic tissue, and then you have this big dead space, Dr. Fadel, this question is for you mainly. What are you using to manage the dead space and manage the soft tissues until you can do a flap to cover it? And say the patient presents late and you already have an infection or signs that infection is brewing. What are you doing to manage the dead space?
Actually, I tried to show what has happened from some colleagues is to be happy by having what looks like a good appearance of a firearm injury wound. They feel that they succeeded and thinking of how can they will do internal fixation. This has happened in my trainee. But the problem is that there is a hidden problem inside. If they didn't, as you mentioned in the very nice discussion, is they didn't understand the pathophysiology, the pathoanatomy, that the penetrating wound is not from one side, it is not a fracture. Penetrating carry with it a higher energy for damaging and also a thermal effect. And what is hidden also is the cavitation or the cavity effect. This cavity depends upon if it is simple or not simple, we can say that low energy or low velocity. In this case, you can do even, you can use even plain internal fixation, whatever be. But in the mid-mild, high energy velocity firearm, you should look either to use internal fixation or external fixation. If it is not, if it is stable, it is a way. Is it if it is a way of complication of the soft tissue? If there is no vascular or neurovascular problems, if no need for extensive or multiple debridement, if it is not questionable around infection to be hidden, in this case, you can go through the internal fixation, no problem. It is guided one by one. You may have the third type, which is absolutely, in many instances, a need for external fixation, which is the high energy trauma. In this condition, you are confronted actually by the pathophysiology of this trauma. You are confronted with damage, thermal effects, and the bone comminution, and the comminuted bone, it is not amenable to be left to be as a calm shell or even a chipping technique for as a bone graft or something, auto bone graft. It is a necrotic bone. So you are from the start know that you have 1/3 of the leg damaged. In this case, no thinking at all of internal fixation by any mean. Either if you have a clean area and cover the area of soft tissue, you can use what is mentioned by Dr. Kafuri or Dr. Haidia. But if the soft tissue also is an insult and the problem, and this is a condition, start from the first by assessing if you have 1/3 or 1/4 even to do monolateral excision, leaving a room for plastic surgery, consult them. If they can do something, it's okay. If they couldn't help us, we can behave by ourselves within limits. If we have 2 centimeters, 3 centimeters of bone debrided and soft tissue, we can do gradual compression and doing shortening, which is gradual shortening. Maybe do it acutely if we are monitoring the vascularity well. We can do it acutely for the tibia and the leg bone. We can do it for 3 centimeters or 4, but with questionable. We should take care of the pulse, the proximity, the pulse of the pedal pulse. But in case of we are afraid, we can do it gradually with no need for plastic surgery. After approximation of both ends of bone, we can do corticotomy of the metaphyseal area, and everything now is clear. We have a docking site, we have a short tibia, and this short tibia we can do lengthening clearly from the metaphyseal area. All this had been done except by using external fixator, and especially Elizarov. In this case, is wiring technique. The wires carry less infection insult for the bone and soft tissue more than the chance. So we have a short limb, we have a closed soft tissue, no need for microvascular surgery or orthoplastic surgery. We can do later on by orthopedic surgery, a lengthening procedure, and no harm of infection. This get rid of many days and many a lot of money for having antibiotics in these conditions. I hope that I covered to some extent the condition.
No, that's great. And actually, we have a fantastic lecture by Jack Wickstead on acute shortening.
Excellent.
Which is available online for free. He gave that last year, so definitely that's an option. So I just want to move to the break now. Just before we move to the break, since Dr. Haida gave the final lecture on this, I want to give a moment for Roman to say a few words before we move to the break, just to summarize some thoughts, and then we'll move to the third section. Roman, take it away.
Thank you, Karan. I think that the case of Dr. Fadel is highly illustrative and very important for all us to recognize. And I think, as Jack also pointed out, the hard thing is not necessarily the bone, it's the soft tissue. And recognizing that as part of the trauma spectrum is really important. And it, unfortunately, though, it is the hardest thing to teach because it's not as objective and it requires a lot of judgment. But I think that if a good debridement can be done at the first or second go to the operating room without regard for what way I'm going to fix the bone, then you have avoided the biggest problem, which is infection. Once it gets infected, you have a much more difficult problem. And based on that debridement, you can figure out how am I going to cover it and how am I going to fix the bone. And there's various options. And as we're seeing with all of today's cases, we have to set up the conditions for healing of the soft tissue and the bone. And we need lots of tools. And whether it's an external fixator or a rod or a plate, each one may be appropriate for that particular situation. And we just have to apply it per the principles that that device is designed for. And then you can have the solutions you need to deal with these complex problems. You need more than a hammer. You need more than just a drill. You need lots of tools and know how each one works optimally and optimize it for its situation. And that's how we're going to avoid problems.
Dr. Kafuri, go ahead.
So thank you for your comments. Just a very important thing I would like to share. It was mentioned about the importance of knowing how to handle soft tissues and how to know a flap as a tool that you should know how to manage. I would say they're very interesting flaps that everybody should be able to pick up without microsurgery. Some of those are the gastrocnemius flaps that are very, very powerful for the coverage of the proximal tibia, and the soleus or hemisoleus flaps that are very important for the mid shaft. Those flaps don't require microsurgical training. They only require understanding of anatomy, especially gastrocnemius. They are very forgiving because the blood supply comes from proximal, and it's very rare that you're going to compromise blood supply unless you go too far proximal without understanding where the pedicle is. The soleus requires a little bit more of understanding of the anatomy, but it's still a very good tool to manage mid-shaft soft tissues problems.
Thank you. Really excellent discussion and amazing cases. So let's take a pause for 5 minutes. We'll come back at 30 minutes past the hour. Of course, for those of you who just want to sit around and continue talking, please feel free to chime in. But we'll move on to the next case presentation by Dr. Juf at 30 minutes past the hour. Brian, did you raise your hand? Did you want to say something?
Yeah, I'll just like to add to Mauricio's comment. You know, for tibia leg flaps, I mean proximal gastrocnemius flap, middle shaft of the tibia, we can use soleus, hemisoleus, and we've been using reverse shoulder flaps very, very effectively for distal third tibial fractures, and we do have very good success rates. So I think as an orthopedic surgeon, these rotational flaps are really, really very essential for for managing tibia fractures with exposed bones.
Thanks, Brian. Brian, are you seeing a lot of these firearm cases in South Sudan?
Yes, we do see a lot of them, and sometimes we actually get, apart from the firearm fractures, we do see a lot of them, and we try to manage them as much as possible. Firearms are everywhere in South Sudan. It's just a country we can emerge from conflict, so we see this a lot. And usually these are rifles, AK-47, and this sort of firearms. But quite interestingly, we do get cases of osteomyelitis, not necessarily post-traumatic. For example, in children, you find a child coming to you with an exposed, tibia, more or less 50% of the tibia exposed, and you have to do something about that. We've started to do bone transport, so we're learning to we're trying to gain experience in this aspect. But yeah, we do get this kind of challenging cases.
And what do you guys have in terms of soft tissue management? Do you have surgery available? Do you have negative pressure?
Sorry, can you repeat?
Yeah, sorry. Do you have negative pressure wound therapy available? Do you have plastic surgery available? What are you doing to manage the soft tissues?
Well, we do it all on our own. We do not have a plastic surgeon at the moment. There is one who just finished his training recently from Sudan, but he did not join us fully. So we do all the flaps on our own. What was the second question? Yeah. Sorry, what was the other question?
Do you have negative pressure wound therapy? Is that something that you guys use?
Oh yeah, we do not have access to negative pressure wound treatment, and that's actually where we picked interest from your pumps. That I just saw it on Twitter, and I picked interest on that. We do not have negative pressure wound therapy, but we're actually trying something interesting. That is honey dressing for open fractures with terrible infection. We find that honey dressing actually does a lot in improving granulation tissue at the fracture site. Sometimes you get granulation tissues creeping to cover the bone, even though it's not as effective as negative pressure wound therapy, but it's something that we're using.
Yeah, I think honey dressings are very powerful. I first was introduced to that by colleagues in Tanzania. I think the mechanism of action is it's basically like a hyperosmotic, compound. So it basically is bacteriostatic or even bactericidal in that sense. Roman, just before we move to the next case, I was just curious, in the situation in Ukraine, what are they like? How are they typically managing these complex injuries that happen on the battlefield all the way up to reconstruction? Can you give us some insight into what the situation is on the ground there?
Yeah. So, as you may know, the fighting is happening mostly in the eastern parts, and so there's a mandatory evacuation from the battlefront to parts further west. And this includes not only the military casualties, but the civilian casualties. And at the early stages, having talked to colleagues, they hardly have enough time to even take in the intake history before they're moving onward. And so they have a very brief debridement and stabilization with external fixator, and then they move on. And that's the hard part, that it's hard to track, to know where these folks are going and what's happened to them and what's the plan to go forward. But a lot of these are in external fixators. Then they get to a definitive facility. The degree and expertise of the surgeons there is variable. And like in a lot of Africa, plastic surgery support is very limited. And so a lot of orthopedic surgeons have learned how to do gastroc flaps and sural flaps and other rotational flaps, which is really useful. And so wound vacs, early stabilization, debridement is really important. And I think that what I have seen and experienced is, and this is common, because of the uncertain coverage and fixation plan is not really established, then the early phases of debridement and stabilization are delayed, leading to the complications of stiffness and atrophy and non-union. And so getting these principles established earlier and having a more robust way of addressing all of these would be more ideal. But given the volume, it's very, very difficult to do.
Yeah. No, thank you, Roman, for that insight. All right. Well, without further ado, let's move on to our last and final section. I'm sorry we're running a little bit behind schedule, but the conversation has been great. So Dr. Diouf from the Gambia, please, Mariam, if you can, go ahead and take it away. Miriam, can you unmute your microphone? We can't hear you.
Hello. Good day, everyone. I am Dr. Ju from Edwards Francis Small Teaching Hospital, and I have 2 cases to present in this conference. Next. The first case is a 34-year-old man who stood by his vehicle when he was knocked by a fast-moving vehicle. He presented with a cross injury of the leg as well as trauma of the same of the homolateral hip. So he presented very early, within the first hour of the trauma. Then all the vitals were okay. Then this patient was admitted at the A&E. Next. Next slide. Hello.
Miriam, you're muted again for some reason. We can't hear you. There we go.
Is it okay?
Now it's okay. Please continue.
So within the first 1 hour, the BP went down to 80 and 50. Patient was tachycardic, drowsy, and pale. HB was also low. It was about 8. Then this patient was started on normal saline. 1.5 liter of normal saline was given, and 1 pint of blood was also given. So we requested 3 pints, but as you know, blood is not always readily available. 1 pint was what was available, and this was what was given to the patient. Next slide. So an initial X-fix was planned for the patient, and anesthetic review was done for the possibility of immediate external fixation. So based on this review, a decision was made to continue resuscitating the patient, and X-fix was done the following day. Next. So the patient was optimized on day 2. Patient was fully conscious, stable. However, on the local examination, the dorsal pedis was palpable but was faint. Posterior tibialis was not palpable, and the toes were peeled. So there was loss of sensation. So with little optimistic, we decided to go ahead and then do the debridement, and X-fix was done, as immediate amputation was something that you cannot think of in the Gambia. You always try to give them the opportunity to have a limb. So in theater, only the posterior tibialis, the popliteal artery was palpable. The rest were not palpable. Go ahead. Next. So the third day post X-fix, we noticed that the toe was already becoming black. However, the patient believed that he was getting better. He was saying that he was feeling everything and he was getting better. We proposed amputation, which the patient refused almost 7 days after the first operation. Then finally he accepted, and then the operation, an amputation above knee was done. Next. So this is how the patient came. This is one of the laceration that the patient came. This was the medially. On the lateral side, there was also a bigger one. Go to the X-ray. Good. So these were the fractures. The fracture goes to as long as to the tibia plateau were involved, and then down to the proximal part of the tibia. And also, if you look at the X-ray, the hip X-ray, the subtrach was also affected. Go. And this is the X-fix that we made. So this was the 4th day post-operatively. So finally, this patient was amputated. Today, the patient is at day 36. Still, the hip is not yet fixed, but the patient want to go for overseas treatment to have prosthesis. Go. Next. Next. That is the end of the case. So that is the end of the first case. So this patient is still around. The hip is not yet fixed. I was waiting for the stomach to get healed properly, and then it will be maybe a DHS, a difficult DHS will be fixed because the stump is very, very short. It's about 15 centimeters from the joint. So, but now the patient is asking for a medical report to go for overseas treatment. So I don't know what are the possibilities, whether I should do dynamic hip screw and then allow for healing before he go for the hip, for this prosthesis or not. Because in the Gambia, we don't have the gamma nail. The only thing that we have for this kind of fracture is the dynamic hip screw. So the second case, should I go to the second case or should we discuss this one first?
Mariam, is this not your second case? This is the one
Yes.
that. This
So
is your
the second. Yeah, go up.
Can you go back 2 slides?
Back, yes, go back.
Yeah,
So
thanks.
the second case is also a young man, 35 years old, a non-psychotic patient who was involved in RTA, vehicle versus, he was walking on the road when he was knocked down by a car. He came with decreased level of consciousness, the deformity of the thigh, and then was not able to weight bear. However, his vitals were normal. Good. So a right closed segmental fracture with malunion was diagnosed. So analgesic skin tractions were given. For this patient, we had a problem because we don't have DHS that were readily available. There was no family member. So luckily when we took him to theater, there was one DHS that was available, which was only 4 hole, but we realized that this couldn't fix it, and then fin nail was used. However, it was very, very difficult, and then the cortex was perforated, and that is the X-ray we have. Go to the next slide, please. So this is the patient fracture. You can see that there is a malunion of the femur. So on top of this malunion, he has a new fracture, which is just above the malunion, making it impossible for nail to pass. Initially, when it was discussed in the morning meeting, because of the malunion, we said that it was not possible to put a nail. So we were going to try to use a long DHS or at least a blade plate. We have few blade plates that are available for patients who do not have money to buy the implant that are available in the country. As I mentioned, there is not also a gamma nail. So we went into the theater. The only DHS that was available for free was 4 hole. It was too short for this patient. And the last option we have was to use the fin nail. And then at the end of the day, we couldn't. It was very difficult to open the canal, and because of that, the cortex was open, and then C-arm was not used. At the end of the day, we have X-ray that was out. Go to the next slide. Next slide. So that is the X-ray, that is the nail that we have for this patient. So all these things are difficult cases. That is why I brought them. It was very, very difficult for us to take any single decision on these 2 patients. Thank you.
Thank you, Dr. Juf. Wow, very tough case. Reminds me a little bit of the case that was presented by Dr. Omojok at the very beginning, where there was a malunion and then a new fracture on top of that. So just before we move to the bone transport cases, I'll just leave the floor open for any of our faculty to comment on these 2 cases of Dr. Juf.
So Dr. Juf, thank you for presenting those cases. Those are rather difficult, and I understand that you have, it sounds like there are difficulties with obtaining certain implants.
Mm-hmm.
One comment and then one question for you. My comment is that early on during the discussions this morning, Dr. Schweizer mentioned the clamshell osteotomy, which is something that can be very powerful to treat this deformity. Now, this increases the complexity of the case, but the clamshell osteotomy technique involves cutting the bone above and below the old deformity and then splitting the intermediate piece. In this case, you may not need to do that because you already have a fracture up above. And so then you can theoretically put the nail down so that it goes all the way down to the distal femur, if you have that available. But that increases the complexity and the number of places where the bone would have to heal, and so that may also be somewhat difficult. So my question for you is, we've talked about sign nails previously. Do you have those available for use at your hospital?
Yes, that is what we have. Those are the only nails that we have readily available. Yeah.
Okay. Thank you.
The nail that Miriam was describing, that thin nail, that's actually a variety of the sign nail. It's typically, sorry, Miriam, you can probably explain it better than I can, but from what I understand, it's originally designed for a retrograde nail, because the thin component allows for basically it to wedge into the isthmus and prevents you from needing to do the proximal interlocks when you do the retrograde nail. Now, I think it was actually quite a brilliant idea for you guys to use it here antegrade, knowing that if you perforated that healed kind of cortex at the malunion site, you'd be able to wedge it in there and be able to get enough of a fixation to stabilize the proximal fracture. I think it was very creative use of the technologies that you had available, Miriam, and I congratulate you on that one. I wonder if you'd considered putting one of those tension band lateral plates on. Did you guys consider doing that, because this is a subtrochanteric fracture?
No, we didn't consider that because of the malunion. It's very difficult. Like, unless we break that entire malunion, it was going to be very difficult to put any plate on that.
Miriam, that's a beautiful case. Really nice, way to handle a difficult problem with a creative implant. I would second, Greg's comment about the clamshell osteotomy being extremely useful in this case, because it would allow you to use a standard sign nail, which diameter-wise is going to give you, an implant that's going to last long enough to get the subtroch area to heal. The problem with using a small implant in the subtroch area is, there's very high forces across that area. And I think there's probably a good chance your nail's either going to bend or break before you achieve union. And a clamshell osteotomy, moving down, 8, 10, 12 centimeters below, right to the apex of that deformity, and then making a transverse cut at that level and splitting that whole deformity in half in the coronal plane allows you to put a long nail all the way down to the distal segment where it's intact. I'm not so concerned with correcting that deformity. It just allows you to put a bigger implant in.
Yeah. Brian, you'd raised your hand. Did you have a comment?
Yeah, I was more in the line of Dr. John on using a clamshell. That would allow you to use a standard interlocking side nail rather than a thin nail. And what we have done in a few cases of subtrochanteric fractures, that we use side nail, and then we can augment it with a side plate just to add more stability, to the subtrochanteric fracture. Because obviously DHSC is going to fail because it's sort of a subtrochanteric with a lateral wall block. So there's going to be a shearing force that's going to fail the implant. Another tool that actually I think is very, very robust is angle blood plate. I know it's obsolete in the West, but over here it's still a very, very useful tool. So a 90-degree angle blood plate can do wonders for this case. Thank you.
Thanks, Brian. Yeah, that lateral plate is what I was describing for the subtroch fractures. I know it's recommended for the sign nails. But anyway, let's move on to our next case, because we still have two fantastic cases to present. I did also want to say that we've been talking a lot about soft tissues. There's a fantastic lecture on the YouTube page for HGOC by Dr. Sami Dolat Shahi on, he's a plastic surgeon, like orthoplastic surgeon, fantastic surgeon. And he goes through the reconstructive ladder and all the different techniques for lower limb soft tissue reconstruction. So highly recommend that. So Dr. Mapur, if you're available, please take it away for this next case.
Yes. Hello, everyone. Can you hear me? Good. So my name is Dr. Mapur. I'm an orthopedic surgeon working at Juba Teaching Hospital. It's a great privilege to present complex limb deformity organized by Harvard Global Orthopedics in collaboration with South Sudan Orthopedic and Trauma Society, of which I'm part of. Next slide. So these are my disclosure. Most of the implant we are using here are donation from Science Fracture Care International. There is no financial or any other interest involved. Thank you. Next slide. So these are my credentials. I graduated in 2010 in University of Bahr el Ghazal. By then it was based in Northern Sudan in Khartoum. I did my M.Med in Dar es Salaam. I finished in 2017. Then I went to Ethiopia for fellowship in pelvic and acetabulum trauma surgery in 2018. And I also happened to sit for a local or a regional exam, which is a fellowship of College of Surgeons of South East and Central Africa in 2021. So I work here at Juba Teaching Hospital as a head department of orthopedic and trauma. And I also teach in University of Juba. And I happen to be the General Secretary of the Society, which is collaborating today in this webinar. Next. Yes, this old male presented to the clinic with limb deformity. He was walking with crutch. He doesn't have pain. He reported a childhood of chronic osteomyelitis at age of 5 years. On our clinical assessment, the limb was short by 6 centimeters compared to the opposite limb. He has no wound, he has no sinus discharge. So that means he has no active infection at that time of presentation. But he has an hypertrophic scar anteromedial to the of the leg. He also has deformity at the ankle joint, but he has a normal range of motion at the knee joint. Next slide. So these are the X-ray we took on presentation, and everybody asks himself or herself, what is the diagnosis at this stage, at this presentation, for example. So if you can see here, the fibula here is maintaining the length of the limb, and you can see a sclerotic fencing-like appearance as at both fragment, proximal and distal, and there is a gap. They are not touching each other. That means there is a gap in between. So when you look at this, we came up with atrophic non-union at the mid-shaft of the right tibia. So that's our working diagnosis. So now, having this diagnosis in mind, what should you do? What will you do? Next slide. So here, because of atrophic non-union, so we are faced here with a gap in between two fragments. So what we decide, we decide to treat this patient by using theta. So we plan to do osteotomy. Before osteotomy, we open the non-union side. We clear out the fibrous tissue in between the two fragments, and we remove the sclerotic part of the bone until we find the bleeding area of the bones. So we were left with about 5 to 6 centimeter length of bone gap. So we put the ring fixator on, and we did our osteotomy at the metaphyseal-diaphyseal junction. Next slide. So doing destructive osteogenesis at this patient, so you have to ask yourself, after doing osteotomy at the metaphyseal-diaphyseal junction, when will you start destructing or transporting that segment? So it depends on the type of patient you are dealing with. For example, in young age, the bone is still active. And in old age, the bone cells are not that much active because of element of osteoporosis and other things. So because of this was a young male or a young person, so we start our distraction at day 5 from the day of osteotomy. So we spend 5 days and then we start doing distraction at osteotomy side. So next slide. So this is the process of destruction of destructive osteogenesis at day 3, or sorry, at the 3rd week. Next slide. So up to here, we achieve docking at week 7. And you can see there is a visible colors that is being formed at the bone transport area. So achieving this, achieving docking side, the question is what is next after achieving docking side? So putting in mind, after achieving docking side, you still have an issue with the length because the limb was short by 6 centimeters. Number 2, there is deformity at the ankle joint. So these are the things you have to incorporate so that you come out with a full length that you will restore later on. Next slide. So these are the questions here. After achieving docking side, you have to think of the length and you have to think of correcting the deformity at the ankle joint. Next slide. So here we took the patient to the OR, we opened the docking side, we refresh the bone ends, and we plate it with the DCP plate. Then we thought of correcting the deformity at the ankle joint. So we did an osteotomy just above the syndesmosis ligament because the ankle joint was not rigid. It was flexible. There was a range of motion at the ankle joint. So we thought the deformity is at the bone level. It's not because of the soft tissue. So that's why we did osteotomy at the distal fibula just above the syndesmosis ligaments. Then we readjust our frame so that we realigned the distal aspect of the frames. So one of you may ask me, why don't you incorporate the ankle joint into the ring fixator? It's because we don't have enough ring fixator, we don't have enough wire, and we don't have enough rods. So that's why we did that. So we later on adjust the distal pin, align it with the distal rod side that we realigned the ankle joint after doing osteotomy at the fibula side. So here, after doing osteotomy and after plating the docking side, we are now transitioning from the bone transport to the bone lengthening, so that we give a length that was not there before after achieving the docking side. Next slide. So after transitioning from bone transport to bone lengthening, this is what we achieved. So the next question is, when do you remove an external fixator or the ring fixator after achieving the bone transport? So here you have to think of the bone healing, because you were transporting the bone, so you are creating a new bone formation at that level. So you have to wait until the bone is consolidated enough to take the weight of the body, so that you remove the external fixator. So at this level, we were patient enough to wait for at least 6 weeks. So we wait for 6 weeks, and then after 6 weeks, we thought the bone has already consolidated, putting in mind the age of the patient also. You can wait longer, up to 3 months, if the bone healing is low or delayed, particularly in elderly patients. Next slide. So this is the follow-up. The patient now is standing in both limbs. Both limbs are equal, of equal length. You can see at, let's assume this as an AP, and the right one is the lateral view when you are observing the patient. Next slide. So at 16 month, you have come all the way from the fixture on the X-ray fixture on the left side to the fixture on the right side. So that's the end of our case. And the rest of the part that we are left, we will discuss it in a discussion that is coming up. Next slide. Thank you.
Thank you, Dr. Mapur. Wow, fantastic case, an excellent outcome, really remarkable. I just want to pause maybe for 2 minutes for a few comments. First, I'd like to invite Dr. Deepa Mapur, if she's available, to maybe comment on this, because she gave a fantastic lecture on bone transport and deformity correction. So, Deepa, are you available?
Hi, yes, I am. Yes. I thought it was a really great case, actually. It's a very nice solution to what was a really challenging problem. It's one of the great things about bone transport is, I think someone said earlier, that you don't have to be afraid to remove as much bone as you need to, because you have the technology to recreate it. And then plating it to gain stability at the end is also great, because it allows the patient to regain movement in their joints and they can rehab faster. So I thought it was a really great case.
Thanks, Deepa. And Dr. Mapur, you answered my question. I was going to ask, why not cross the ankle joint? Because I think that would have been easier to maintain the alignment of that distal fragment. But you answered that question already. It was the limited resources. But I think given what you had available, you did really a remarkable job. So we have one last reconstructive case before we can open it up to conversation. Thank you all for being patient. We're at the top of the hour, but we'll certainly have time, I hope, for Dr. Daniele Sciuto's case from Kenya. Daniele, are you available?
Yes, Kiran, I'm here.
Great.
Thank you so much. Very happy to be with all you guys. Not so happy to be the very last one, so try to keep it light and interesting.
We're saving yours for last because it's so interesting.
Thanks for everyone to holding on. Huh? Okay, are you seeing my screen? Because I have to share my screen.
Yet.
Can you see me?
I can see you, but I can't see your screen yet, Daniele.
Okay.
Oh, now we can.
Okay, can I go?
Yes, please.
Okay, so this is the case I'm sharing with all of you. It's a 19-year-old boy who fell from a tree. So it's important we see the date. This was December 2021. Okay, exposed tibia 8 hours before arrival in our hospital, and then the debridement after 6 hours from arrival. So now I'm sure some of you, or probably everybody of you, is asking, hey, this is a complex trauma webinar. Why are you throwing at us such a simple fracture? And this gives me the opportunity to actually jump to one of the conclusions. That was one of the home message also of Dr. Ahida, very nice video, which he was saying, I don't have enough to stress about the importance of debridement. And so also I like how they put this, like why. So sometimes we have a lot of challenge. So this debridement doesn't happen immediately in our hospital. But it's also true that sometimes, because this patient come to us in a very delayed, so sometimes they come 6 hours, 8 hours, 12 hours, even 24 hours. I have to say that in the back of our mind, we kind of tend to relax a bit, in the sense that we say, okay, I mean, this guy has already stayed there 12 hours, a couple of hours more doesn't make a difference. This brings one of my points, is said, okay, we cannot control what happens before the hospital, so we cannot act on that, but we definitely can act when the patient arrives to our hospital. And I think this is one of the home message I want to deliver at the beginning. So anyway, it took many challenges, took 6 hours to go to the OR. The debridement was done. There was apply POP with a window. Maybe we can discuss about that also if you wish. And what happens, you know, the report was like, patient is doing fine, patient is doing fine, patient is doing okay. So after 5 days of patient doing well, that was the situation. Okay, so actually it was a lot of pus infected. And so when I saw the wound, I said, okay, let's go straight to theater, open the wound, look at the bone. I think all of us can say this bone doesn't look so well. Did the debridement and kind of extensive debridement, because also sometimes we have the tendency to pay a lot of attention to the part of the bone which is exposed to the trauma, but not so much to the hidden part of the trauma. So sometimes there is a lot of dirt, a lot of soil, a lot of pocket hidden. So again, the debridement has to be no shy debridement, I would say. Aggressive debridement, good debridement, make sure that we remove everything. So at that time, what I did, together with the debridement, put a ring fixator on the distal part, because somehow I was foreseeing, or I was fearing, was going to happen next. And I only used wire because the distal fragment was so little. So I said, let me put something that can minimize the trauma to the bone, the small bone remaining. So also I cover with the rotational flap. I think some of the colleagues before said also this is a very handful flap. So I tried to cover as much as I could also the defect. And I mounted let's call it hybrid X-Fix. So it was an hybrid X-Fix. And I would say it's a real hybrid X-Fix, because if you, for those who are keen, you can see there is at least 3 types of external fixator combined together. You know, this company, they like to do fixator, they don't match. But if you're a bit creative, you can match them combining. And so this was the post-op. So unfortunately, that was I was fearing was about to happen. So you can see the soft tissue were not healing. So you say, hey, that bone that looked very white to me is not a healthy bone. Probably it's that bone. But you know, maybe sometimes you're busy. There's a lot of cases in the world. You buy time. Now this is how I look at 5 weeks. Now here you have the certainty that those soft tissue are not going to heal. I mean, that's a dead bone and nothing is going to granulate or grow on top of that dead bone. So there was no other option to go for the plan. So those 5 weeks also gave me time to get my brain ready for the next step. And this next step, you know, this was the pre-op planning. So make sure so to transform that hybrid fixator now using the last ring to a full ring fixator with ready for a tibia transport. So usually I do this with the patient because most of our people have never seen a ring fixator and never seen external fixator. So for me, it's very important they understand what they are going to face when we're talking about long bone defect, when we're talking about tibia transport. So this was the day of the operation. And so I kept the last ring, and then I dismantled the rest. I did a radical debridement, removed all the dead tissue. And when I mounted, I actually did an acute shortening. The nice presentation also on the video, or Dr. Wicksteed said, I think it's quite handful. And I didn't shorten completely because I just shortened enough for me to close comfortable the soft tissue. So this was the post-op. So I prepare everything for a tibia transport, proximal osteotomy. And as you can see on the yellow, this is how I get the alignment. So with because having a ring already set has some limitation, okay, when you try to align. But with this, simple flag from Elizarov, you can get a fairly good enough alignment. So as you can see now, remove the dead bone, boom, just the soft tissue healed nicely and heals very fast, despite the condition, sometime of our setup, the contamination of the local dressing and, our situation sometimes is tough, but still the biology of healing of these people is amazing. So despite of that, soft tissue heals very well. So this was the follow-up of 1 month. Transport is going well, it's progressing. Soft tissue are also healing. And this was, now we are hitting March 2022. And this was the final alignment and the compression. So what happens here? So now, when we're almost reaching a good time, I change the last part of the external fixator, and I'll show you in the next slide what I mean, and to achieve a very good alignment. And when I have a very good alignment, I did that full compression. As also Dr. Fadel was saying, the good thing is this patient, they walk, they need some assistance, but they're not staying bad. So, and they are not all the time in the hospital. They just stay home, you train them. The lengthening was done by him alone. So this is what I meant. You can see the difference. This was the previous, before the alignment. So with just some simple conic, a convexity washer, and then you can build kind of a motor with some simple part of the Elizarov. So basically what you do, you just release a bit the bolt, and then with the motor, you can mobilize in a frontal view and in a sagittal view until you get a good alignment, and then you lock it completely. You compress it, lock it. So this is kind of a basic but very effective way. That is the work that the modern hexapodalic external fixator does. And also we had that very nice video from Dr. Frumberg. So the fact that maybe that hexapodalic technology is not available, we have other solutions to get a good alignment, good compression. Usually I do this, you can plan for this, and I do this in theater under the C-arm, so I don't exhaust the radiographer. You can plan it. One day the C-arm, the operating room is free. You can go there because you need a fresh mind, you need to think, you need to be happy with the alignment. And also can be very useful, have someone to check with you, have a good friend, a good mentor, a very expert in this kind of procedure that, you connect in theater, you say, hey, how does it look to you? You direct, you can adjust. It's always good not to be totally alone. And today's technology help us a lot. So this is something you can plan. You cannot do chop. I mean, you cannot do fast. You need to do this part with a fresh mind. So this was after the alignment. So this was, we have reached in May 2022. And his patient is progressing well, so we can go fast. This was finally the removal day, and it was June 2022. So once you reach the compression and the good alignment, that's now the point that you know how much you want to continue lengthening the tibia transport, because only when you have that compression, that alignment, you know how much you want to continue up to go back to the contralateral length. So now this is June 2022. So that's why I call this presentation Cheap is Expensive, because once again, the whole message is debridement, good debridement is a key. Sometimes this case gets very complicated. Maybe, I say maybe, not 100%, maybe could be avoided. This kind of pattern of tibia fracture, if everything goes well, maybe they heal and weight bear in 7 weeks, 8 weeks. This one took about 7 months. Okay, so this was the follow-up, August 2022. So patient, for our population, their pastorally long distance is very important. And just for making Kiran happy, I just recall last week the patient, I said, can you come? So this was follow-up April 2023. And patient is walking fine, and I think he's doing fairly well. Okay. So just to close up, I think the home message from my side, once again, is early debridement. Let's try not to use our challenges in our setup sometime to sit back and relax. So we have to be aggressive and do good debridement. The second one is, there is a way to also handle this complex case without hexapodalic. There is a way, so it's a possibility, ready available for everyone. And also the last one is acute shortening. Sometimes can be a very good tool when you are in this situation for soft tissue. Thank you.
Thank you, Daniele. Phenomenal presentation. I think you combined a lot of the concepts from some of our lectures, which was really lovely. I think that's why we wanted you to go last, and it sort of covered some of those key learning points. Since Dr. Mapour gave such a great presentation on bone transport as well, I'd like to invite him to comment first, and then maybe Dr. Mohammed Fadel, because your presentation was also on bone transport, so I'm sure you have some comments. Dr. Mapour, can you comment?
Yeah, thank you, Daniel, for your nice presentation. Daniel, by the way, Daniel has been my...
Dr. Mapour, can you hear us?
Also been coming. I understand the situation is practicing in is like us.
Hey, that's a pity. He was about to say nice things about me.
Example, you
well, Dr. Mapour, maybe you could use, if you're in the same room as Dr. Brian, you could use his computer, because I get a good signal from him. Maybe Dr. Fadel, can you go first? Can you just say a few comments, and then we'll go back to Dr.
When the limb is stable, it may disappear. So that's the situation we are facing here in South Sudan, like our neighbor Daniel. But otherwise, the case he has just presented and everything he has just put, the energy and the time are very wonderful, and you can see the success he has just given to that patient. Thank you.
Thank you. May I repeat my thanks for Kiran and the group of Harvard. Actually, you did a lot of, we can say, green hands for those low and middle income countries. Actually, I am in love with Africa, and I'm living in Africa. It's my homeland, Africa. So I would like to have it a chance that you have SICUT in Cairo. As I am a board member elected in Egyptian Orthopedic Association, I am actually inviting you all to share. It is cheaper to come with us in Egypt, even by aeroplane. It is cheaper than other SICUT to be in Europe, for example, or for Kuala Lumpur, such as last year, who Kiran got 3 medals, I think. So I promise you, if you come Egypt, we give 4 medals for you. So I invite you. You have such good cases. We still have 2 days for abstract submission for SICUT. Please present your cases. These fantastic cases, and you should put it under sub-Saharan complex cases. It will be accepted. So please, we have many cases today, and the privilege for Kiran is to present 5 or 6 new abstract submitters from Africa. It is very nice if we got up from this meeting by this outcome of research, because either to publish or to share in a presentation, a conference, or to perish. So Africa have a treasury of cases. We are doing the future of the world by many cases which is not well known for them. So please try to add this facts. Otherwise, we are doing bad by our basic cases. We have a lot of cases, and Kiran will help us, and me also. I am so near and close with you, and Kiran has the organization who can help us all. So again, please share, and we have still 2 days for SICUT abstract submission, and I know that many countries from Africa have a good relation with SICUT association. Thank you, Kiran. Thank you, Daniel and Brian and Amambur, and all the team of South Sudan Orthopedic Association.
Yeah, I just wanted to echo Dr. Fadil's comment. We at HGOC stand ready to help all of you guys. If you guys do need help preparing cases for submission to CCOT, it's a wonderful opportunity, but obviously, like, you guys probably don't even need help. The complexity of these cases and your sophistication of your approach is just really amazing and was on display today. So thank you so much. Any other comments from the faculty on these last two bone transport cases? Deepa, Jack Wickstead, Dr. Frumberg, you guys gave lectures that I think covered some of these concepts. Any comments?
Well, these are beautiful cases that, you know, if anything, they illustrate that what you need is really good judgment and thoughtful care. You know, you don't need a computer controlled system here, right? You need good judgment and patience, and really, these are really excellent cases. There's just nothing to add.
Yeah, I agree with that. I think basic principles, proper debridement, proper planning, you know, they solve more problems than computers. Yeah.
One thing to add technically that we saw on Dr. Scudo's case that was just presented is he really took the time to mount his frame orthogonally to the limb. And if you actually, it takes a lot of time, and that's, I think, a lot where the learning curve starts off and why people maybe are shying away from this kind of treatment. But if you have circular frames and even unilateral frames, if you really take some extra time and maybe put a wire through the joint so you can orient yourself, really palpate the tibial spine, try to get the limb aligned and mount the frame orthogonally, even though you can convince a frame to translate or angulate, you saw how easy it was for him to go to the operating room and correct the alignment later. So if you really take a couple of extra minutes, even take an extra half hour and really try to get your frame to be perfectly in line with the limb, you don't need fluoroscopy, and you certainly don't need to exhaust your radiographer, as he said, to try to get your final corrections to get your alignment perfect. Really impressive. Thank you, everybody, for allowing me to be here. I learned a lot, actually, that I will take back. And poor Dr. Tesso in Ethiopia, when I send him some rings, he's gonna have to present at this next year some of the crazy cases that he's going to be doing. So
you'd be more than welcome, and thank you, David, for joining us. Any other comments from the faculty before we move on to our concluding slides?
Thanks for your group and for the attendee.
Thank you. Okay, well, let's wrap it up since we're a little bit over here anyway. Oh.
Can you hear me?
Yes, we can hear you. Go ahead.
Yeah, so I'll thanks Kieran and the team. It's really a wonderful conference where we get to share a lot of challenging cases, and this is actually the situation in most sub-Saharan Africa. So I can say that we speak for the resource limited settings, and the conventional teaching is that the conventional teaching in books, let me say, is those of resourceful settings. But I think we need to, take an approach where we can actually publish more on treating certain types of fractures in resource-limited setting. This will give an opportunity for, for us to share our experience, and for the trainees who are coming up and working and being trained in resource-limited setting to be able to, handle cases that they face on a daily basis. I think there was a question on earlier on the use of sign nail and how easy or how difficult is it for people to get trained in using sign nails. I would say most sub-Saharan Africa, I would say Eastern Africa to be specific, Kenya, Uganda, Tanzania, where I received my training, where Dr. Mopo received his training. Most of these countries actually use sign nails for fixation, which is a very versatile type of nail, and more or less this is what we use in this region. For some of, from Egypt, for example, Egypt and northern part of Africa, they do have access to other type of more expensive nails because they do have the resources. But sign nails are usually not very difficult to master. It just needs a few cases and then you're up and running. So that's my call. Let's just try to do more papers on treating fractures in resource-limited setting. Thank you.
Thank you. Great concluding words, Brian. And I agree with you completely. I think the knowledge and skill and ingenuity of African surgeons to handle the complex challenges they face is just really amazing. And I think anything that any of us can do, I think if I speak for any of the, perhaps all of the speakers from, the United States, we all stand ready to support however we can to elevate your voices. And I hope that this conference has done that in some small way. So just as way of conclusion, next slide, please. I just wanted to say one final thank you to everybody for their participation. The faculty were amazing, the cases were amazing, the conversation was great, both the live conversation as well as the conversation in the chat. Really, thank you so much. And thank you for Medal putting this together and for helping us deal with all the technical challenges that inevitably occur when dealing with unstable internet and multiple speakers. Next slide, please. So we do have a certificate of participation that will be available for folks who attended the live session and can complete the course evaluation. Next slide.
Hello,
thank you
Kiran?
for joining. Oh yeah, hello.
Yes, I'm waiting for my presentation. Is that cancelled?
Oh, Dr. Abraham, we thought that you didn't make it. We
no.
we were trying to find you. I'm so sorry. Yes, we have your presentation as well still. I'm sorry for that.
I can make it in 10 minutes.
That's great. If for those of you who are available to stay for Dr. Abraham's presentation, it'll be phenomenal. This is the plastic surgery.
That's going to be short one.
Yes, please go ahead. We'll end the formal part here, and we'll just leave anybody who wants to stay to listen to Dr. Abraham's presentation. Go ahead. Thank you so much, everybody, and please, Dr. Abraham, you can go ahead.
Can you share?
Yep, we can share your slides. Just give us a moment.
Thank you. Share.
Yeah, give us a moment. We're just trying to find them.
Till then, I can continue with introduction. Is that possible?
Yes, please go ahead.
Yes, thank you very much. I am Abraham from Ethiopia. I'm a plastic surgeon working in Addis Ababa University, the School of Medicine, Alert Hospital. I was asked just to put a little bit of meat on what you were discussing, that it has been a lot about all the complications and big cases regarding to the bone. I just want to do something regarding to the challenges. What is the challenges in low-income countries, particularly with low extremity reconstruction? One of the challenges that everybody was talking about resource limits in those countries where that cases are coming late. Late arrival is one of the reason. The other is what I see is that there is no sort of that coordination with plastic surgery and orthopedic. So the principle of orthoplastic joint venture is not as such a common thing like in low-income countries like ours. That's another thing that what I have seen in a lot of that registrars in orthopedics is that trial of closures, and that because everybody is scared of having that exposed bone. So I saw residents that doing that minimal debridement and trying to close with a sort of pressure, and later on coming with big defects. So these are some of the things I just want to comment. And to go next slide, please. My slides are on that representative of these cases. This is one of the patient who came late. Late arrival is one of the difficult part. And if you see the reconstruction of particularly with the soft tissue, either it can be the upper third, middle third, or lower third. It has been discussed that during the previous presentations. One of the major issues is that we are a little bit so conservative regarding to debridement. because we are afraid that to leave the bone exposed. And at any cost, that at the end of the day, we are going to face a dead tissue with exposed bone with late comers. That is one of the challenges. This is one of the case which I received recently. A 15-year-old male patient who involved in a road traffic accident with sort of crash involving the middle third and the lower third, including the calcaneus. If you see that this patient, he had X-fix done, initial debridement was done somewhere else before referral to our hospitals. But the time when the patient arrived, that there is still a patient needs more debridement with exposed calcaneus, lower tibia, and all the vital structures are gone, particularly with the medial part, the posterior tibial and all the. So on this patient, well, this is one of the challenge. This is a 15-year-old. So the challenge is that there are deep structures are gone, the bone is exposed. So maybe that still there might be a sort of argument. It's better to do an amputation and putting patient on prosthesis. And there are also that people might still argue that there is a possibility that to reconstruct this leg. So in my view, that somehow that relatively acceptable limb might be better than prosthesis rather than that. Definitely that prosthesis might be financially that acceptable because you can leave the patient, discharge the patient from the hospital earlier. Anyway, that this is a badly crushed lower leg with extensive soft tissue, with neurovascular structures are gone, as I mentioned. Next slide, please. Next slide. Yes. Then, well, what we plan to execute on this patient is that doing extensive debridement, which is left from the first procedures. And then, as I mentioned before, that you have been discussing about the soft tissue coverage. For the proximal ones, usually it is easy. There is no any need that to do sort of microsurgical type of interventions. Gastrocnemius is a good one, that everybody can exercise the gastrocnemius. As such, it's not a difficult one. Unless and otherwise that somebody is trying to dissect more proximally and damage the pedicles, but usually it's unlikely to damage that because it's coming higher up in the condyle. The other issue is that with the gastrocnemius, that you can take full gastrocnemius or even half part of the gastrocnemius. In the middle third of the leg, that solace is the famous one. Still solace, that sometimes we also do what is called the classical solace, or sometimes you can do also the reverse type of, which is rarely you can do that. But in case of the reverse ones, solace, it is only you are allowed to take half of the solace so that the reverse is going to get vascular supply from the other side, from the distal ones. For the reverse solace, you can also use in an area which is junction of the middle third and the lower third. That is one. But in cases where it is involving the lower third, that was the challenge. And the microsurgical technique is the vital areas where you are entertaining or the muscle flaps and the fasciocutaneous flap like LT. What happens in areas where you don't have the microsurgical facility, because that is one of the demanding skills, demanding sources. So this is one example of that challenge where if you don't have the microsurgical facilities in a patient, where you don't need to do an amputations. If that is a small wound, small bone that is exposed, you can use also what is called the peroneus brevis muscle covers, which can cover around the ankle one. But like in a patient, these ones, the best option is going to be what's called the delayed wrap-up type of that cross-leg flaps. Cross-leg flaps can be a classical sural type, or it can be that wrap-up. In wrap-up, that you can do either medially based or laterally based. On a medial based type of wrap-up fasciocutaneous, you base it on a perforator which is coming from the posterior tibial artery. On the lateral ones, you can use that one, a perforator, one of the perforators, what usually I'm using either the perforator that's about 4 centimeters above the lateral malleolus, or about 8 centimeters, or usually about 12 centimeters. On these particular areas, there are commonly a persistent perforators that are coming. So based on that ones, you do a delay one. For this one, we use both the middle and the upper ones, and we did a delay. The importance of a delay is that you can glove almost nearly circumferential part of the leg to cover the counter part of the defect on the other leg. So X fixation was, both extremities was done. The donor site was covered with skin graft, and the patient was put on X fix so that the patient is not going to rip off the flap. Next slide, please. Next. This is what was done for this patient. So almost that the left lower extremities nearly about 60-70% of that the skin was already degloved based on the medial perforators from the posterior tibia. That's covering almost the whole tibia. What was done is that we did decortications, both the calcaneus and remaining dead tissue on the tibias, and the patient was kept in these positions for 3 weeks. Next slide, please. Then on the 3rd and 4th week, that we divide the flap, covered most of the lower and the lower third of the tibia, but which we couldn't make it is that on the classical calcaneus where we did the soft tissue. So this is one was a challenge. In a best setups where you have all the facilities, this is a classical case for free flaps, particularly with latissimus dorsi, or also the fasciocutaneous flap like ALT. So as previously mentioned, that it's not a big issue. That knowing that all type of flaps or all type of microsurgical that interventions. If one surgeon knows at least one flaps like ALT, then almost 100% you can cover or you can address the wound. That is one classical case. Please, second case, shortly. Next slide, please. This is another patient, a 34-year-old male patient. Particularly, this patient is comorbid. This is a patient with retroviral infection on treatment, and he involved on road traffic accident. At the same time, because I just wanted to present that the most difficult area, because on the middle third and the proximal third, usually it's not difficult. The lower third, depending on the extent of the wound, one, the structure that is involved, second, and the third is that the tissue involved, that's another issue. So in this patient, that is a patient with type 3B, where there is that big defect, big soft tissue defect. So still, I just want to emphasize debridement and extensive debridement. That is the issue on that. If you are going to be a little bit conservative, then all the cases that were that present with even with Daniel, that letting the wound a little bit late, it sometimes that we are going to face a dead bone, which are going to remove it, and then all the procedures that were mentioned are the sequel of that being relatively conservative regarding to aggressive debridement. So I am in favor of doing as much as possible big and that aggressive debridement, and that is the main issue. And the second issue is that we have to do that as much as possible. After doing debridement, within a maximum 48 to 72 hours, we should be able to cover that area with the soft tissue, whatever soft tissue, either local or regionals or cross-leg ones. That's one. So for this patient, that because this patient came from far away, from the east part of Ethiopia, that's about 430 kilometers out of Addis. He had a primary that conservative debridement with X-fix in one of the orthopedics units. I wish that there was a sort of orthoplastic type of joint ventures, one to do that aggressive debridement and to do some soft tissue coverage. So for this patient, the only thing that the dorsalis pedis was not palpable. The posterior tibial alter is okay. Definitely the patient had foot drop, but the extensor hallux is intact. Next slide, please. That the X-ray showed that a big defect on the lower third of the. So for this patient, that what I did is that that based in one of the perforator I mentioned, that is from the peroneal artery, particularly on the middle and about 4 centimeters and 8 centimeters perforators are usually persistent. You can find them constantly. So based on that one, that we raised fasciocutaneous, good fasciocutaneous flap, covered that ones, and there was one thing that was mentioned about how are you going to fill a gap. That's what I heard a discussion. In that case, if you have a muscles to cover from the local area, that's good. Like this one, that you can also put the peroneus brevis muscles as a pack and to do that the fasciocutaneous flap. Or sometimes if you have a big fasciocutaneous flap, the proximal ones, you can depithelialize the tissues so that you can bury that one as a pack, and the remaining part you can use as a cover. So that's also another good issue to cover the shallow area or the cavity. That's also another issue. So for this patient, that after doing proper debridement, doing fasciocutaneous flap, pack that once, and put the skin graft on donors. Later, that as you see on the left side, the flap was good. The areas properly packed. That recently, the last 2 days, we opened that one. We put the bone graft. We remove the X-fix, and the orthopedicians working with me, they put the plate and screw with the bone graft. So that's also another issue. And these are some of the classical challenging cases. That in fact, I could have brought that cases from the middle insert, but I just want to discuss the most challenging one and really problematic cases, particularly in a case in institutions where patients are coming late with infected bones or semi-debrided or in sort of conservatively debrided. So that the message is that one important thing is that still, as everybody mentioned, debridement, aggressive debridement is important one. The second is we have to that as much as possible cover the area with soft tissue, whatever available soft tissue, either the muscles or the fasciocutaneous, and we have to proceed with the other ones. And in a patient who are coming late, that is one issue, that we are using on and off with limited vacuum dressing, but we have a limited at 1 or 2. We have, and one of the vac was supplied by, thank you very much, with Kiran. Is he donated one of the vac, so we are using that one. So that's also another issue. But the problem is that usually when we are using the vac and honey dressing, we are really looking for healing by secondary intentions. And in that case, tissues around the injured area is edematous, fibrous ones, and the secondary that flap coverage is usually a little bit challenging compared to the primary, so that we shouldn't miss the best chance that is in the first 24, 48 hours. Thank you very much.
Dr. Abraham, phenomenal cases. I just had one question, actually, it was from the chat. For the calcaneum in the first case, what was the soft tissue flap that you used to cover it? Was that a reverse Searle flap?
No, that's not. There is what's called the crane type of flap, and the crane flap is that you cover the area with sort of the flap, part of the flap. When it granulates partly, that you take the flap as a flap for other area, but the granulation tissue you put with the skin graft. So that is because initially we couldn't make the whole thing to be covered by the what's the wrapper flap. So we managed to cover the wrapper flap, the whole tibia until the calcaneus, but the calcaneus was it was granulating, so that we just put skin graft.
I see. Okay. All right. Wow, truly remarkable cases. Sorry that we were almost not going to hear them, but I'm so glad that you jumped in and were able to present. And the number of people who stayed on the call to hear them, I think, is testament to how fantastic the cases were. Dr. Abraham, I wanted to also thank you for all the work that you've done to train so many plastic surgeons, because I think these skills are so valuable. We have had other presentations of Searle flaps and these cross-leg flaps, but none presented by a plastic surgeon of your level of expertise. So I really thank you for going through sort of tips and tricks on that. Thank you so much, everybody, again, for participating in this. Thank you, Dr. Abraham, for finishing the conference on such a high note. I'll remain on the line, and for anybody who has any comments or questions, the floor is open. Otherwise, we'll say thank you and have a wonderful rest of your day for those of you who want to log off now. Thank you so much, everybody.